can post the links because this is an iPhone, right? YouTube link, is it?
Yeah. Hi, a very good evening to everyone, and welcome to the webinar of Indian Fertility Society Special Interest Group at ICMR-NIRRCH, co-hosted by both of them, on Preimplantation genetic testing, controversies to consensus. I welcome all of you on behalf of the Institute, and I request our director, Dr. Gitanjali Sachdeva, to welcome the gathering and say a few words about this activity. Over to you, Dr. Sachdeva.
Everyone, and welcome to this webinar jointly organized by National Institute for Research in Reproductive and Child Health, Mumbai, and Indian Fertility Society.
Can't hear, I think.
Yeah.
Am I audible?
Dr. Sachdeva, the voice is a little bit low. Could increase it a bit.
Is it better now?
Yes, yes, definitely. It's better. It's better.
I hope many of you have heard about NIRRCH, but for those who don't, our institute NIRRCH was established in 1970 by ICMR. At that time, the mandate was to devise new strategies for fertility regulation. And so the Institute undertook a lot of studies in terms of contraceptive trials, devising new strategies, and also understanding very fundamental mechanisms which underlie basic reproductive processes. But as the society changed over the years, the Institute also kept changing its mandate in tune with the changing needs of our society, especially in the context of reproductive health. So currently what we are doing, we are trying to address various researchable issues in terms of male and female infertility, women's health, child health, and also pregnancy-related disorders. So this is what we had been doing. And when it comes to ART, probably some of you know that the Institute played a key role in the birth of India's first scientifically documented IVF baby. And currently, when it comes to ART, we are trying to do studies related to health technology assessment of IVF procedure for their possible introduction into our health program. We are also trying to understand poor quality of oocytes in women with PCOS. We are trying to identify uterine factors which leads to recurrent implantation failure. And some of our scientists are also engaged in developing several technology. For example, Dr. Modi has recently transferred a technology for detection of Y chromosome microdeletion to an industry. Similarly, we are in the process of developing another device which would help us in sorting good quality sperm. So this was about what Institute is currently doing. Now coming to our co-host, Indian Fertility Society. I've been told that it's a young society established in 2005, but it has very impressive membership. I think it has more than 3,000 members and 29 chapters. So it's a good thing. And interestingly, we do share some of our goals. Like I've been told that the society major goal is to disseminate novel knowledge and also to inculcate the spirit of science in those who are engaged in reproductive medicine. So I think this webinar is a step in this direction. And this webinar, which is being convened by Dr. Deepak Modi, who is leading this special interest group in applied genetics under the aegis of IFS. I think it's good initiative and very timely initiative in the sense that the field of PGT is really growing. Now we have really moved on, like from 1990s when we were using probably polar body biopsies to assess aneuploidy. Since then, we have grown to like cleavage stage biopsies, then trophectoderm biopsy, and now we are talking about non-invasive PGT. So the field, like from using simple PCR, it has moved to using NGS. So it's becoming more and more affordable. So that clearly means that there are very there are many chances that this PGT would be offered to many patients in the coming year. But this needs to be regulated, considering that now there are evidences which are emerging which suggest that embryo mosaicism, embryo's ability to self-correct, and also some trials which indicate that even after transfer of embryos with aneuploidy, you do get euploid babies. So there is a need to revisit the field and also to probably reach to a consensus in terms of the guidelines or practices which should be adopted for PGT. So before I mute myself, I would like to thank all the experts who have agreed to deliver their talks, or who are ready to, who have been very generous in sharing their wisdom. And also I would like to thank for their time. And I wish you all a very scientifically stimulating evening. And with this, I will just stop here and hand over the mic to Deepak.
Thank you. Thank you so much, ma'am, for those very kind words and the great words of wisdom, which is going to set the tone of the meeting. Just before we start formally with all the presentations, let me just quickly run you through the entire aim of this meeting. So the whole idea is the special interest group, Indian Fertility Society, is to understand what are the current practices of PGT happening in the country, and using all the information that's currently happening around, we derive some consensus documents so that in India we can practice PGT in a more efficient way, as Dr. Sachdeva has mentioned. And the key coordinators for the IFS is myself, and I have Dr. Sheetal Jindal and Dr. Siali Kandari, who have been taking the lead role in this part of the special interest group. And just to remind everyone, and for those who are unaware, that this is the second of the such series of meetings. The first meeting was in Fertivision 2022 in Hyderabad, where we had a physical meeting, and we had a series of discussions happening around this area about prenatal genetic testing, preimplantation genetic testing. And some of the documents were developed. The whole idea, the objective is to understand the overall clinical and laboratory practices for preimplantation genetic testing in India. For this document, we will cover PGT-A, PGT-M, and PGT-SR. These are the three main domains in which we will be discussing for today. The idea is to discuss the practices and devise guidelines to carry out good practice for PGT in India. Also, one of the aim is to carry out a survey to determine the current practices by different clinics, embryologists, clinicians, how they are conducting PGT in this country. And then eventually, by the end of such meetings, we will develop draft guidelines or recommendations which can be used by the clinicians in this country, and also decide the way forward how the entire PGT business should be carried out in this country. And the entire overview, the presentations today are divided into two major sections. One section is going to cover about the clinical practices which are happening in PGT-A, and for PGT-A we have Dr. Gunashila, who will be discussing about it. We have Dr. Sheetal Jindal, who will be talking about her experience with PGT-M, and we have Dr. Ritu, who will be discussing about her experience with PGT-SR. And this time we are joined by Dr. Fiona, who will be largely talking about the laboratory practices which are currently present in the country, and how the laboratory practices also should be benchmarked so that PGT can be effectively used for everyone. Talking about this survey, I would request now Dr. Sachdeva to launch the survey in the Q&A section for the public to take it up, and eventually this will be also posted on the YouTube. So that everybody can take up this survey. I humbly request all of this to please circulate the survey widely, and eventually use it up so that the data can be accumulated, and the very accurate data should be accumulated so that we can use it for the guideline development. Dr. Sachdeva, please.
So Deepak, I can see Q&A. Where should I go?
Maybe can you paste the survey link there, ma'am?
Survey link.
Yes, I have sent you. I'm not sure if you have.
I think you did send me. Can you do that for me?
I will do that.
Because that was on mobile, so
Sure.
I don't have handy.
Sure.
Please do that.
Okay, I'll request Sayali to do that. The moderators, Sayali, can you do that for us, please?
The link is live in the YouTube chat.
Great. The link is live already on the YouTube chat, and I think we can paste it here as well. So all those requesting who are joining here can use the link from the Q&A section. Those who are joining from YouTube, please use the link there to pass it on to others as well. And please fill up the survey. Those of you who are joining from YouTube may please post the questions in the chat section. There are our moderators, Dr. Zoya, Dr. Sayali will paste the questions here and they'll be answered. If you have any comments to make, please feel free to do the same as well. Thank you so much. Sayali, could you paste the link, please? I can't hear you.
I'm trying to paste the link. Just give me 1 minute because it keeps logging out of my laptop.
Ouch. Ouch.
Yeah. So
okay, I
just
think
1 second.
it's been done by...
No, that's a document link. That's not a form link. So just give me a minute. Yeah, just give me a minute. We'll quickly do that. In the meanwhile, if we can have some introductions, I'll do it till that time.
Sure. So I'll request all my speakers to have a quick round of introduction. Let me start with myself. I'm, as Dr. Sachdev has mentioned, I'm Dr. Deepak Modi. I'm a scientist at this institute, and my lab is interested in understanding the fundamental mechanisms which are involved in embryo implantation and how things go wrong there to cause recurrent implantation failures. We're also interested in understanding molecular basis of endometriosis. In addition, being a trained geneticist, my lab also is involved in developing fertility genetic assays for understanding, for diagnosing for causes of infertility. And we have developed a Y chromosome microdeletion assay for the Indian population, which can be used for various, specifically for the Indian population, so that we can get a more accurate diagnosis. Over to you, Dr. Gunshila. Can you please introduce yourself?
Yeah, I'm Dr. Devika Gunshila from Bangalore. I'm the managing director of Gunshila Surgical Maternity Hospital. We are, I think, one of the oldest private small-scale hospitals practicing infertility still in India. And we have our own genetics lab, we have our own genetics lab, and we are I think we were the first ones in Karnataka to have an in-house lab doing a lot of infertility genetics. And I think that's all, and I'm grateful to this whole team for having asked me to present my talk today, which will be our experience on using pre-implantation genetic testing for new bodies, who benefits and why. So thank you.
Thank you so much. Dr. Sheetal.
So hi everyone. I am Dr. Sheetal Jindal. I am a senior fertility consultant at Jindal IVF and Sant Nursing Home, Chandigarh. And so ours is also one of the pioneer center, and we were the first to give the first IVF baby to Chandigarh in this part of the country. And since then we have been, so our first baby was born in 1994, and since then we have been contributing to the field of infertility. And we gave the first PGT baby in this part of the country again. And so that is my area of interest. And I would be sharing today my experience with the PGT cases, with single gene disorders. And looking forward to an interesting session. Thank you.
Thank you, Dr. Sheetal. Dr. Ritu, are you there and can you hear us? Can you unmute yourself?
Hello everyone, good evening. I am Dr. Ritu Hari, a medical geneticist working at Kraft Hospital based in Kerala. We are actually the first one in India, in fact Asia Pacific, to have the first NGS installed at our lab. We are into PGT, SR, MNA since past 11 years now, and also into NIPT. So we deal with a lot of PGTM cases, and we're the first one to start with linkage analysis and haplotyping on NGS. Also, I'll be talking on my experience today based on PGT-SR because I have been privileged enough to work in both first generation based PGT-SR technology, that is FISH, and also on NGS. So I'll be happy to share my views. Thank you.
Thank you, Dr. Ritu. Dr. Fiona.
Hello, everyone. I'm Dr. Fiona. I'm the head of scientific operations at Anderson Clinical Genetics. We are a genetic service provider for India and her neighboring countries. I'm actively involved in developing new diagnostic assays in the reproductive genetic segment, ranging right from PGTs to prenatal testing and neonatal testing. And today I'll be sharing my views on the protocols observed by different genetic laboratories and how you can make the right choice for your diagnostic service provider. Thank you.
Thank you. My co-host, Dr. Zoya.
Hello, my name is Zoya. I'm a senior scientific researcher at a startup called Fertility, which is based in the UK. We basically use AI and blood samples to help triage people for 7 of the most common gynecological conditions. I happen to also be a reproductive geneticist, and I look forward to having this session and taking all your questions.
Thank you, Zoya. And finally, Siali. Siali, if you're speaking, we can't hear you. Neither we can see you. Yes.
Yeah, I'm trying to troubleshoot the problem. I'm not able to. Yeah, so I'm Dr. Saili Kandari. I'm basically the CSO, Chief Scientific Officer and Director at Selcha Biotech and Research Center. I'm Laboratory Director for around 5 laboratories in India. I am associated with 7 companies, either as on the Scientific Advisory Board or as Chief Scientific Director. My role has been in oncofertility since the last 15 years, and the last 13 years I've been in clinical embryology. I have had around 5 international publications in this time. My interest in PGT has been from a decade ago. I have also been responsible for the first NIPGT baby of India with a concurrent trophectoderm biopsy. And beyond that, my interest in, is continued in this area. Thank you.
Thank you, Siali. So we'll start with the formal presentations, and I'll request Dr. Sheila to take over for the first talk. Ma'am, before you start, requesting others who are not the co-host here, but who have joined through the WebEx platform, can you please confirm if you can hear us? Because somebody who tells me that they can't hear. Ritu, when you were not the co-host, could you hear us? Yes, okay, people can hear us. Thank you so much. Thank you. Ma'am, you can start, please.
I think, Dr. Gunashila, you're not audible. Probably you need to unmute.
So sorry, just trying to get that started. Can you hear me now? Can you hear me?
Yes, yes.
Yes, okay, fine. Yeah, full screen model. Yeah, okay. My topic for today is our experience on using PGT for aneuploidies, who benefits and why. Next. Now, going to the history, and the introduction, pre-implantation genetic testing is the use of reproductive technologies for the genetic analysis of embryos prior to transfer and implantation. The primary purpose of PGT-A is to improve an IVF transfer outcome by reducing the number and effect of aneuploid embryo transfers inherent in morphology-based embryo choices. And this has become an integral part of assisted reproductive technology. Next. Yeah, so Edwards and Gardner in 1967 used eucrosine 2GNX vital staining technique and stained rabbit blastocyst sex chromatin. The preparation was observed under a fluorescent microscope, and this technique, as it was potentially mutagenic, was not compatible with embryo transfer. In 1990, many groups started using PGD technology for testing for aneuploidy and translocations by fish and monogenic disorders by PCR. And in 1999, Wells and Voller demonstrated the use of comparative genomic hybridization technology on human blastomeres to check for all aneuploidies of all chromosomes. After 2010, several other methods were developed for comprehensive chromosomal screening, such as SNP testing, qT-PCR, and the next generation sequencing. And in 2013, NGS became very popular because it had a shorter testing time and was more cost effective. Next. Preimplantation genetic testing involves analysis of DNA from oocytes or polar bodies or in vitro fertilized embryos, mainly blastocysts, for determining genetic abnormalities of a HLA typing. And it includes three modalities: PGT-A, which is for aneuploidy, pgtm, which is monogenic or single gene defects, and PGT for chromosomal structural rearrangements. Now, there are many causes of low implantation rate in IVF, and some of the most important being an altered endometrial receptivity, different transfer efficiencies, and chromosomal abnormalities despite normal embryonic morphology, especially in patients with recurrent implantation failure and advanced maternal age. Now, PGT-A testing has 5 potential benefits. It prevents trisomic offsprings by analyzing the chromosomes. It reduces spontaneous abortions. One of the benefits is to reduce multiple pregnancy by minimizing the number of embryos transferred, to improve implantation and decrease time to pregnancy. At least 40 to 60% of human embryos are abnormal, and the number increases to 80% in women 40 years or older. Implantation rates in embryos transferred during IVF procedures ranges from 30% in women less than 35 to 6% in women more than 40. So the risk of having no chromosomally normal blastocysts for transfer is considered lowest in, it is about 2 to 6% in women less than 37, and rises to 33% at age of 42, reaching 53% at age of 44. Now, what are the indications? Older patients who desire elective single embryo transfer, and PGT-A to improve pregnancy outcome for patients undergoing IVF, recurrent implantation failure, advanced maternal age, recurrent pregnancy loss, and improving implantation rates. Next. The potential candidates for PGTM would be patients who are known to be at an increased risk of an offspring with a specific medical condition, patients who wish to give birth to a child with a compatible HLA type for stem cell therapy of a sibling, which we call as a savior sibling, and patients who wish to avoid sex-linked disorder in the offspring, patients who wish to avoid passing a suspected but unconfirmed autosomal dominant gene to the offspring. For PGTSR, it would be obviously patients with a balanced translocation at risk of recurrent pregnancy loss from an unbalanced translocation. Now, at Gunshila, we started the PGS system, PGS with NGS technology in January 2016. We introduced PGS for the following reasons. There was a complete change in the patient profile, with many more patients coming with failed IVFs and recurrent pregnancy losses, and our patient profile also changed from being, women less than 35 to women more than 35. Next. So our indications for suggesting the option of PGS included advanced maternal age, recurrent implantation failure, severe male factor infertility, chromosomal aberrations in any of the partners, recurrent pregnancy loss, known translocation in any of the partners, and history of heritable diseases in the patients or in the affected children. Now, this is looking at all the patients who underwent PGT-A. So we had 889 patients, and a total of 2,751 embryos were biopsied. The euploidy rate was about 44.9%, aneuploidy rate was about 40.8%, and we had a mosaicism rate of about 11.6. Next. Now, amongst the total patients who underwent PGT-A, 597 were eligible for transfer, and we've talked about fresh biopsy and frozen biopsy, because fresh biopsy were the ones who were actually programmed for PGT-A, and we had the blastocyst on the day 5, and we did the biopsy and then froze it. And the frozen biopsy were women who came back after a failed cycle and said that they wanted a PGT-A on their frozen embryos. But anyway, about 361 patients underwent the transfer, and the pregnancy rate per ET was 56%, with a biochemical pregnancy of 2.7, abortion rate of 5.5%, and the ongoing and delivered patients were 47.5%. So now what about age? Now with increasing age, we know that aneuploidy increases with age and successful implantation decreases with age. And when we looked at 1,000 of our embryos, we found that segmental aneuploidies remained the same regardless of the age, whereas aneuploid embryos, which are in the red, increased with the increasing age, and the euploid embryos decrease with increasing age. So in women over 37 years of age, we had 153 of them and we had biopsied a total of 446 embryos with a euploidy rate of 43.1%, aneuploidy rate of 47.7%, and a mosaicism rate of 9.1. So there were a total of 70 ETs that were conducted, and we had a positive pregnancy rate of 58%, and ongoing and pregnancy and delivered were 50%. There were, now if you looked at women, the embryo details of women who were less than 38 and more than 38, the total number of patients in the less than 38 group were 716, more than 38 were 173, and there was a 37% aneuploidy rate in women who were less than 38, and more than 38 it was 52.57. Now, this is in sync with a study by Keating et al., who talked about aneuploidies with age. So they looked at unbiopsied embryos and looked at PGT embryos. And as you can see, the implantation rate at the age of 31 was 46.7%, at 35, 36.8, and at more than 43, dropped to 8.5. Whereas with the PGTA group, between 31 and 35, it was 57.6%, and at the more than 43, it was 47.3, compared with the 8.5 in unbiopsied embryos. And similarly, with the ongoing pregnancy and delivered rate, it was 16.7 in more than 43, and remained in the unbiopsied group, and remained constant between 55 and 48% in the PGTA group. Next. Now, in our women, if you looked at unbiopsied and PGTA embryos in women more than 37 years of age, the ongoing and we had a positive pregnancy rate of about 41.2% and 56% in the PGTA group. Ongoing and delivered were 27 in unbiopsied and 47.5 in the biopsied and PGTA normal euploid group, and the abortion was 10% in the unbiopsied and 5.5% in the PGTA group. Now, what about recurrent implantation failure? We had 235 patients, and a total number of 648 embryos were biopsied, out of which we had a euploidy rate of 51%, and euploidy rate of 38%, and mosaicism of about 10%. We had 155 embryo transfers, and we had about 55.5% pregnancy rate per embryo transfer, and the ongoing delivery rate was 48.3%. Now, this is a very interesting article which by Paul Pertier, which I recommend everybody should read, published in Fertile Cell 2021, where they looked at 4,429 women who had up to 3 consecutive FET cycles with a single euploid embryo, with the mean age being 35.4 years. And they had a sustained implantation rate of all the 3 cycles between 69.9 in the first cycle, 59.8 in the second, and 60.3 in the third. The cumulative sustained implantation rate after 3 FETs, single embryo transfers and transfer of euploid embryos was 95.2. Cumulative live birth rate after 3 FETs, single embryo transfers was 92.6. And the conclusion of the authors was that true recurrent implantation failure is rare with embryo transfer of euploid embryos, and less than 5% would fail to achieve a clinical pregnancy rate with 3 embryos being transferred which were euploid. So now what about recurrent pregnancy loss? Now we had a total number of patients of about 107, biopsied embryos were 311, and euploid embryos were 48%, aneuploid was 38.9, and mosaicism ranged between, was about 12, and our mosaicism rates have ranged between 10 to about 12%. Next. We had a positive pregnancy rate of about 59%, and ongoing and delivered were about 50%. Abortion rate was about 4.4%. Next. This is a study by S.J. Butt et al. In human reproduction, where he looked at large number of cycles, 4,116 with no PGTA and 4,288 with PGTA in women who had recurrent pregnancy loss. And the live birth rate with no PGTA was 33.6 and with PGTA was 47.7. At the end of the day, women who remained not pregnant in the no PGTA group was 41.7, and with the PGTA was 31.1. This is another slide by Dr. Firuza Parikh, who actually showed us a forest plot where the clinical implantation rate favors PGS, and as does the sustained implantation rate beyond 20 weeks also favors PGS. Next, please. Now, this is our study where we looked at rebiopsied embryos, and so the first time result, the biopsy result is on the left, and the rebiopsy result is on the on the right. And we had this. It basically explains that we had rebiopsied 17 embryos from 8 patients underwent PGS. Out of 17 rebiopsied embryos, 6 embryos turned out to be normal, 10 abnormal, and one inconclusive. So we transferred one rebiopsied normal embryo, which resulted in a positive pregnancy test. Next. And so that was the positive pregnancy test. And the others who have had normal embryos are still to come back for a transfer. Next, please. Now, these are concordance studies that we did in the initial phase, because I was very worried about whether we were getting the correct results. So it's a very colorful slide, but then it's colored like that because each of the numbers are, you have the trophectoderm and the ICM, which have been biopsied. So the concordance is quite good. And with only, I think, number 6 and number 19, these were whole chromosomal aneuploidies. Next. And in the segmental also, the concordance was good. Next. And you can look at the 6th embryo and the 19th embryo showed normal when there was a partial aneuploidy present in these embryos. So that gives a concordance rate of about 90 to 91%. Next. These are very small numbers that we've done. We've done pgtm for sickle cell anemia, DMD, polycystic kidney disease, glycogen storage disorder, and achondrogenesis type 1A. Only sickle cell anemia and achondrogenesis have come back for their transfers, and they've become positive and delivered. Next. PGT-SR, we won't go into this. Next. So I want to talk about mosaicism. Now, mosaicism is very, very important because quite often we get results where we don't have any normal embryos, especially in older women, and we do have mosaic embryos. So mosaicism is, I want to spend a little bit of time on this. Mosaicism is defined as the presence of more than one chromosomally distinct cell line in a single sample originating from one individual. For example, if a woman is Turner mosaic, she will have 45X and 46XX. The diagnosis is inferred from the presence of an intermediate chromosome copy number, that is between monosomy and disomy, or between disomy and trisomy, on a next generation sequencing profile. At the blastocyst stage, the incidence of reported mosaicism using NGS methods is highly variable among clinics, ranging from as low as 2 to as high as 40%, but majority of clinics, it ranges between 5 and 15%. When a cutoff was of 50% was employed, low-range mosaic embryo showed a higher ongoing pregnancy rate, lower miscarriage rate, and at least for the studies using the NGS technique. And a recent non-selection trial by Kapalbo reported no difference between the outcomes after transfer of a low-range mosaic group to 20 to 30% abnormal cells and a moderate-range mosaic embryo 30 to 50%. A rebiopsy showed that increasing levels of mosaicism were linked to increasing rates of full aneuploidy. So if you had a higher mosaic rate, you were going to get a full aneuploidy rate. Next. So this is a very crowded slide, but I just put it in because looking at one or two of the studies, the first one was looking at the prospective study. There was Victor et al. Who had 100 embryos, mosaic embryos that were transferred. He had a 30% combined ongoing pregnancy and live birth rate. 8 of the 11 amniocentesis with confirmed normal embryos. 3 of 11 showed a chromosomal abnormalities of unspecified clinical significance, and the spontaneous abortion rate was 18%. We also looked at some retrospective studies, and if you look at the last one, Zhang et al., 102 embryos, mosaic embryos were transferred. Live birth rate of 47% was obtained, and they said that all infants were found to be healthy after a detailed examination performed by the local pediatrician after delivery. They also had a abortion rate of 20%. Next. Now, this is another very good article by Viotti et al. In Fertile 2021, where he compared 5,561 euploid blastocysts and 1,000 mosaic blastocysts used in clinical transfers. The euploid group had an increased implantation and ongoing pregnancy and live birth rate compared with the mosaic group. So the implantation rate with the euploid was 57.2 versus 46.5 for the mosaic. Ongoing pregnancy and live birth 52 versus 37. Low abortion rate 8.6 versus 20%. Whole chromosome mosaic of less than 50% has significantly more favorable outcomes than the more than 50% group. Now, this is another group. This is another slide that actually tells you from the same article about the ongoing pregnancy rate and the implantation rate for all mosaics. It was 47.7 when it was less than 50, and about 39% when it was more than 50. And ongoing pregnancy rate was 42.1 and decreased when the mosaicism was more than 50%. Segmental mosaics did much better than the whole chromosome mosaics. Next. Now, maintaining PGTA's classical binary system of normal or abnormal is disadvantageous. Grouping mosaic embryos with the normal category will decrease the rate of implantation and increase miscarriages, while dumping them or lumping them with an abnormal category would result in discarding a lot of viable embryos. To increase the likelihood of positive clinical outcomes, embryos of mosaic category should be stratified by their mosaic traits, level, and type, and ranked for transfer. So clinicians should understand, these are the recommendations by ASRM, ESHRE, and the PGDIS. So clinicians should understand the prevalence of mosaic PGTA results issued by the reference laboratory. They should also have in place a policy regarding the reporting and management of mosaic embryos, and everybody in that who are dealing with these patients and these embryos should understand that policy. The transfer of embryos deemed euploid should always be prioritized. So if you have a euploid embryo, that should be given priority to any other mosaic embryo. Next. If no embryos are euploid and are available for transfer, then depending upon the clinical situation, and if you have mosaic embryos, then the patient should be counseled, could be counseled either for a rebiopsy, or should be counseled for another cycle of IVF, or should be counseled for transfer of these mosaic embryos. And if transfer of mosaic embryos is considered, then there has to be a lot of genetic counseling with a genetic counselor who actually has specific knowledge of perinatal and pediatric outcomes associated with chromosomal mosaicism. The PGT report terminology should reflect the fact that a trophectoderm biopsy cannot provide an absolute determination of mosaicism in the remainder of the embryo, and we have seen that also in our own rebiopsy samples. Now, the other thing is that mosaic embryos should be stratified by the percentage of mosaicism, whether specific chromosomes involved, by monosomy versus trisomy, whether full chromosome versus partial chromosome is affected, by the number of chromosomes involved, that is single versus double versus complex aneuploidies. Now, in the prenatal and pediatric population, cytogenetic mosaicism involving nearly every chromosome in monosomic and trisomic form has been reported in association with congenital abnormalities, IUGR, intellectual disabilities, and or long-term health problems. So this, the genetic counselor and the clinician should know. Now this is the PGDIS recommendation. Embryos with a higher level of mosaicism may be associated with less favorable outcomes compared with embryos with a lower level of mosaicism. And the relative percentage of mosaicism seems to be a better predictor of outcome than the specific chromosomes involved. Now, if there's a choice between two embryos, for the transfer of two embryos with similar levels of mosaicism, then one should actually go back to the morphology of the embryo and transfer the embryo with a better morphology. Next. Now, the other recommendations are that patients are to be counseled that any genetic test based on sampling one or a small number of cells cannot be 100% accurate because it's a combination of technical and biological factors. Patient information and consent forms for aneuploidy testing should be modified and include the possibility of mosaic results. Genetic counseling with a clinical geneticist is mandatory, and this has been repeated in all the recommendations very, very clearly, and you should have an experienced genetic counselor. So in conclusion, PGTA is here to stay, with a large number of clinics in the world, especially in the USA, adopting this technique. Over the years, there has been an increasing debate about the competence of this technique and its results. There are very, very many proponents and also opponents, the same number of opponents for the same. But it would, or I think it would be wise to analyze our own data from our centers before we make the decision to support it or not. So thank you very much to all of you for a patient hearing. Thank you again.
Thank you so much, ma'am. And I really loved your last statement where you said that, the proponents and opponents equal numbers, and it's wise that we use our own center's data, our own experiences to take a decision making. And as a part of IFS, that's one of our goals, that what sort of recommendations should we have for this country. So I'll quickly share the PPT which we have started with, which you remember, which we had discussed at length in the Vertivision. We will revisit that once more. So all those who are not a part of the Vertivision then can also have a look at it. And we will quickly run through the questions there, and all the participants here who are able to talk can please unmute themselves and answer, or those who are unable to talk can please put in the questions in the chat box on the WebEx platform or on the YouTube platform, and they'll be discussed here. So I think the verdict is clear that there's no role of PGT or PGTA for all. There is no role. We cannot just indiscriminately apply to it. Do we all agree to it?
Yes.
Yes.
Wonderful.
Yeah. People who are here, yes.
Yes. And do you think that it has no role? I mean, overall PGT, does it improve pregnancy rates in non-indicated cases? Do we think that that's still or it's now gone? We don't even consider that.
Well, in my opinion, it is not going to increase cumulative pregnancy rates.
All right.
Definitely not going to make a difference for cumulative pregnancy.
So we're talking of indicated cases. Yes, Sally.
So in terms of non-indicated cases, there is, I think, also a role, and there are proponents for reducing time to pregnancy for patients.
All right. Okay. So I think that's one more discussion which we need to have, is to consider whether we can look at it from reducing time to pregnancy. Okay. So Ali, please make the note that this is something which we need to discuss in our next meeting. So indicated cases, we are talking about recurrent implantation failure, recurrent pregnancy losses, which Dr. Kunusila has very nicely explained from her experience, at least, that there has been a positive outcome in these cases. Long-standing infertility and multiple losses, perhaps recurrent pregnancy losses, should also be considered as a part of the PGTA spectrum. Advanced maternal age more than 35 years, and severe male factor, mainly azoospermia or severe oligospermia, should be considered. When we talk of recurrent pregnancy losses, I think we had some level of discussion, and we can redefine it now. What is the number of abortions that we need to consider? Now, we can assume that a woman who is coming to the IVF clinic is already, at an advanced age, and should we wait for 3 abortions to happen and then consider her for a PGTA, or we think that we can redefine this, redefining RPL for the IVF segment? Dr. Gunishila, you're coming first.
Yeah. Okay, the thing is that the definition of recurrent pregnancy loss itself is two pregnancy losses. So that is kind of a universally, shall we say, accepted definition all over the world. And if the patient is, of course, there are so many reasons for pregnancy loss, and not just the chromosome of the chromosomal aneuploidy of the embryo. But if you also need to take into account the patient's age as well as her opinion. So she may just say, no, I only had two losses and I don't want to go into so much of detail. Or she may say, yes, I'm getting older and I want to get there. So it also depends upon the patient's opinion. I don't think it should be used as a universal strategy for all women. I think we should put into account certain number of clauses, like, for example, the patient's age, her opinion. It should be definitely discussed. And we should give her the option, but whether she uses it or not is a different story.
All right. Okay, great. Thank you.
I just
Anybody
want to
wants
add in
to-
here.
Sure.
I just want to add in here. So just 2 losses does not mean that the female should undergo IVF and along with that, on top of it, PGT-A.
Yeah.
So as ma'am has rightly pointed out that just 2 losses, the female myself, herself would not be satisfied. So I think 2 losses should be if the karyotype of the couple is normal, and in spite of that, if she's continuing to have 3 losses, then probably that could be a setting where maybe you can just think of doing a PGT-A.
Okay, so this is in case of
Comments from Dr. Devika or anyone here around who is there.
Just I wanted to add a comment there that when we talk about 3 losses, let's say a woman who is naturally getting pregnant. Now let's say there is a woman who is coming to the IVF clinic, who is undergoing a pregnancy, who gives a pregnancy outcome but has first trimester abortion. So should we wait for her to miss 2 times her pregnancies and then offer a PGT-A, or that she's infertile and she already has 1 abortion? Do you think we can kind of reconsider it?
Can I answer that?
Yes, ma'am, please.
See, the thing is that patient who may come to the infertility clinic because she may want to have an IVF or something. But like Jeeta said, we don't need to jump into an IVF, especially if she's young. You must tell her that there are so many other reasons than just this chromosomal abnormalities in the embryo, which can actually produce the loss. So maybe in a younger woman, it would be wiser to wait and say that we will look at all the other things, all the uterine factors and infectious causes and anatomical causes. So many other factors are there, alloimmune, autoimmune causes. And then if everything is then ruled out, and then maybe we can think about PGT, but not for somebody who's young and who's had 2 abortions. Like I have people who have had 5, 6 abortions who are young, but still do not want to go in for an IVF. So really, when they come to me and we tried out everything, and then it's not happening, then we would say, yeah, maybe now we need to do a PGT-A. Yeah, but then if it is an older woman, shall we say 40 years of age, and whose AMH is decreasing, and she's already had 2 abortions, then I think we must run towards getting her a chromosomally normal embryo and trying out the best option for her, which would be IVF, to get her a pregnancy.
I think the data is not robust out here, and to find such sort of data is going to be pretty hard.
Yeah.
So just like if you have 2 or 3 abortions and then you should jump in for an IVF and PGT-A, that would be I think extrapolating too much.
Great. So I really love this controversy, and we need to come to the consensus. So all those who are listening to this webinar or will be listening to the webinars on the recorded platforms, if you have any experience with RPL, recurrent pregnancy losses, and if you have any different opinions or your opinion, please do share with us. We'll be happy to look at it and discuss it further. Anybody else has any comments to make, or we can move to the next question?
So I only just wanted to make an observation
Sure.
from the comments of Dr. Ganushala ma'am and Dr. Sheetal, is that it's not just one indication that might move the patient in clinical practice to PGT-A. It might be like a multiple factorial decision. So probably this is something like indicated cases. This is like the basic indication that will allow us to take the patient for PGT-A, but not necessarily is sufficient to take the patient for PGT-A. So I think we should have a series of questions looking at, or a series of questions for the focus group looking at whether there are any group of indications that are even lower than the ones that we have shown, where the patient really needs to be taken for PGT or really is required to undergo PGT or would benefit from PGT.
Great. Anybody else wants to, or can we move to the next question?
Can I have a comment here?
Sure. Sure.
Yes, ma'am. Yeah.
I have a question regarding non-invasive PGT-A in such cases in young patients. I mean, would you advise that?
Yes. Anybody wants to answer?
See, it's my I've had a few discussions with so many people in India and abroad, and I don't think the verdict is still out conclusively for non-invasive PGTA. When we are going to be talking about it, I think we need to be very careful with discussing with patients, because there's a lot of other problems with maternal cell contamination. That is one of the big things that people have not been able to get over. So I would like some of the geneticists also to kind of comment on that, maybe.
Sure. So,
can I comment, Deepak?
Yes, please.
Yeah, so with the non-invasive PGTA, the problems have been really come out as a challenge. There is no maternal cell contamination when we are doing a Malbec technology. That is, it is looping the DNA, it does not allow any bias amplification. So that MCC part is ruled out. And I think NIPGTA will be the future, because the use of laser is reduced. Plus you can detect low level mosaicism. Mosaicism actually discards embryos in regular PGTA, classifying them as a pure mosaic. But when you do an NIPGT, you come across those things being low level mosaic. So you cannot cancel a transfer cycle, especially for women who has low number of embryos. I feel, as per my experience, NIPGT doing would be a good idea. Also for cases like male infertility, as for example, Klinefelter syndrome or XYY syndrome, where you have an indicated case what you need to look for, NIPGTA definitely holds good. And practicing it from
RPL in young patient. RPL in young patient.
I would also like to add something here. So most international societies do agree that NIPGT is still in a nascent form and not fully clinically applicable. And its overuse in the Indian subpopulation is something that should be taken with caution, because the data that is generally accepted for the validation of the test is for sampling on day 6. So if you're not ready to take your embryo to day 6, that is not a technology that you should be using.
Great. I completely understand, and I really again love this controversy. So as a part of this, in fact, just yesterday, me and Siali were sitting together and discussing, and there will be a special subgroup will be created within the SIG who will deal with NIPGT and its current status in India, how it is used, and what is where we are and what is going to be the roadmap. So stay tuned with the IFS-SIG, and we will have more information on it in time to come. And I think, Sally, we need to really prioritize this part of it. Just a quick question. Great. Thank you. Do we consider, ma'am, this is a question for you, which we have not discussed. You briefly mentioned that for single embryo transfers, would you consider PGTA?
That is me, yeah?
Yes, ma'am.
I don't think so.
You don't think so? Okay. So if anybody has a different answer, please do let us know here, or even it's a part of our survey question. So those of you who are unable to answer it straight, please answer it to the survey. We need it, because there have been a lot of papers which do suggest that we can use PGTA for single embryo transfers, but at least Madam's experience has been that there is no great benefit of doing that. But if anybody has a different answer or even the same answer, we'll be happy to consider it. Ma'am, when do you consider a rebiopsy? When you say that, okay, there's no DNA or there's no result from the genetic lab. In all circumstances, do you consider a rebiopsy, or there are special considerations you would give?
When all the embryos, when there are no euploid embryos for transfer, so we have actually in our report.
She's getting.
Can you hear me?
Yes, we can.
Okay, in our report, how our lab report comes out as is that, you have the patient's name and the number of the embryo, etc., what was coded, and then you have the abnormality, and then you have the mosaicism is very well documented, and the level of mosaicism, and then again, of course, euploid and aneuploid, and also they give you a confidence interval where they're saying that they're highly confident that this is a aneuploid embryo, or moderately confident. So the confidence interval is or the level of confidence is given. So if there is if there's an euploid, obviously that is going to be transferred. If there is no euploid embryo, then I would look at mosaicism, which is the low level. And until now, we've been using a cutoff of 35%, and then I've just been reading, and then they said up to 50% is also okay. So talking to the patient and putting in a mosaic embryo would also be okay. Again, if you look at the PGDIS consensus from the earlier years, they say that putting in a monosomic embryo should be preferred to putting in trisomic embryos. that's another story. But then there's a chart which actually talks about that. So anybody can download that chart and you can look at that with the preference of embryo that you're going to transfer. And the other thing is there are some partial monosomies, partial trisomies, etc., which are these segmental problems that if they have a moderate confidence interval in our report, I would tell the patient maybe you need to do a rebiopsy for these. So, and definitely in my chart, which I showed, we had quite a few of these embryos that were mosaic that came out as normal, that had a low level, less than 35% of mosaicism, that came out as normal. So we have about 6 or 7 embryos that were mosaic and that have come out as normal and which are waiting to be transferred.
Anyone else wants to change anything here or add more?
Yes, I do. So rebiopsying will depend also on 2 main categories. One is the quality of the embryo, and second, what is the intended test? So PGTA, we will definitely follow what ma'am is saying. She has perfectly summarized it. If it is PGT-SR, I think we should, because
So now we'll come to this when we do discuss PGT-SR. We'll repeat this exercise when we do SR. Great. And what do you do when there are no embryos, no result embryos? You know, like, okay, you don't finally have anything that you have that you would really wish that you can transfer based on the PGTA test. Do you just ask for the patient to repeat the cycle, or do you still want to give the patient an option of just transferring embryos without any results as well?
Actually, ASRM actually says that recommends that you talk to the patient about one more cycle. That's what they say. But I mean, this is if they have all abnormal and high confidence of abnormality, etc. And no, I mean, whatever we talked about is not applicable. Rebiopsy, etc. is not applicable. Then they ask for us maybe a second cycle to be done. And I don't, if I have a complete aneuploidy, which is of high confidence interval, and I talk to my scientific director and she says, no, don't bother putting that in. And, I'm very confident that this is a problem. I definitely don't have the courage to tell the patient to put it in.
Okay, great.
So it's a combination decision.
Yes.
Yeah.
So I think this we have all agreed upon that who explains the need for the test for PGT-A. It is primarily the clinician who decides that, and rest of the people just follow it. Who decides when, which test needs to be done and where? Typically, again, the clinician comes into the picture. Now, who explains the limitations and risk of the misdiagnosis? In our previous meeting, we had agreed to be the clinician along with the counselor as well as a counselor. Any changes do we want to make here? Anybody else wants to comment here, or we are all okay with it?
I think who decides which test and where it is to be done, it should be with the geneticist, right? Along with the clinician.
So Dr. Sheetal, we have added all these questions in the survey. And in the survey, all the, available options have been given: clinician, embryologist, genetic counselor, geneticist, any other. And, all the respondents have an ability to even add any other person in the next question, if there's any other. So we have given qualitative entry points wherever they're required. And even in the pre-workup, we have given some multiple options and any other if they are doing. So we have kept it quantitative and qualitative. So hopefully we should be able to get their answers. If multiple people are deciding, they can select multiple options.
So my only concern here is that when we talk of having a geneticist on board for a condition like PGT-A, with the volumes of cycles that we do in this country, do we have enough geneticists or genetic counselors to support every clinic that is doing it? So, putting it as a part of the recommendations, all those who are listening to this webinar or considering this, please understand that when we put a recommendation, yes, it's always nice to have the best of it, but that may not be always practical. So we don't want the guidelines landing up being non-practical for our country. We must understand that we have very limited genetic counselors and geneticists in this country to support our system. So maybe we can reconsider this, or our results of our survey should be able to get this clearer answer. But all those who are answering the surveys also, please talk about your practice, what you think it is important, and not just the best practice, what we want in this country, because adding a geneticist will not be a problem. But once we add a geneticist as a guideline document or as a principal document, then we may not be able to go back from it. We have options of revising it, but we need to be a little more pragmatic in this approach. Any pre-workup. So I think for a PGT-A, generally we would consider karyotyping and Y chromosome microdeletions. Any other pre-workup that anybody recommends, or you think that neither of these are very crucial and we can straight offer PGT-A to the couples?
How about adding fragile egg screening? Because that's gaining importance. And for women with premature ovarian failure or DOR, I think they are the candidates for fragile eggs testing.
Agreed. That's the important point. Yeah.
All right, great. Thanks, Ritu. Anybody else
Thank
wants to add, remove some of the pre-workups, or we are all okay with this? And do we want to consider this pre-workup essential, or we think we can get away with not doing anything as well?
I think Dr. Deepak, you should really mention YCMD test designed by ICMR, which is on the Indian population and not based on the Caucasian population, which doesn't even pick up the right partial deletions.
I think we will have to do a separate webinar on that just to
Yes,
absolutely. Dr. Deepak, I have a question for you.
Sure.
Do you recommend YCMD testing in non-mosaicism patients, or is this only for alternative parameters?
No, this will be only severe azoospermia and severe oligospermia, not for all. No, so YCMD in male factor. Should this be a better way of representing it? Great, thank you.
So SOAT and
now coming to the preparedness of the IVF lab who is wanting to do a PGTA program. I'm sure many labs are already running it, but somebody who wants to start it all the way, or who wants to revise the best practices. So we thought that we are okay. Either you can have an in-house lab like what Dr. Gunashila has or what Kraft has, which it was running. But at the same time, you can have an external lab also. We are okay. Every lab doesn't need to develop an in-house lab. We are okay. What are the minimum number of embryos which you would recommend for a PGTA cycle? This was one answer which we could not come to a conclusion in our last meeting, and I think we need to debate on it now.
I think it depends, Deepak, because I had come across 4 patients in last 10 years who repeatedly had a cycle. Their first cycle ended up in all being aneuploid. They were the group of patients who experienced RIF. So when the
Ritu, just to reframe the question, that if you, this is just a couple with an indication who has come for the first time wanting to start with a PGTA. If there are only 2 embryos available, would you consider the patient for a PGTA or recommend an embryo pooling? That would be the question.
I think embryo pooling would be better, minimum 5 to 6.
Minimum 5 to 6. Anybody else wants to change? Dr. Gunashila, what is your experience?
Yeah, I think a minimum of 3 should be there, or 2 is also okay. The patient has only 2. See, the thing about it is that PGTA is expensive. It's not an easy, simple test that can be done. And IVF itself is an expensive whole proposition. So adding on PGTA to it and saying, I would like you to do, X number of embryos, which is going to be a huge burden to the patient. So at least 2, if not 3.
Great. So here comes, you see the controversy that the lab feels more the better, but the clinician says that no, I don't think my patient really wants to really have too many to be tested. Even if it's 2 or 3, we are okay. So I think this is where the clinician's perspective becomes very important. So I request all the clinicians to please take up the survey and give your opinions about this. Witnessing, Zoya, you had a point.
We have an interesting question in the YouTube chat box, which asks if we can do NIPGT instead of PGTA for a single embryo. And since we're discussing this whole situation of like minimum number of embryos, I think that would be an interesting question to discuss.
Yeah, I think, this is from my personal perspective that NIPGT needs to be considered seriously. I think it's here to come and stay, but we will have a separate webinar on that. But if anybody wants to make a very quick comment, we should do it because we are really running late. We are already we are halfway through our time, but we have not even reached halfway in our schedule.
So in terms of, we had this one question where there was rebiopsy and we had added a point in the survey saying NIPGT for the embryo that has been already biopsied to avoid, basically doing a biopsy again. So I think that was where the point was.
I think this is a great opportunity. I think we should record these questions and we'll discuss this when we have our NIPGT meeting separately.
Yeah. So all the questions are on the YouTube link. So we'll copy it once it's done. Yeah.
Fantastic. Witnessing, we said it could be done manual or automated. We don't really insist on any one of them. A previous experience of the embryologist, we were confused within whether we should have the embryologist who has experienced at a minimum of 100 biopsies before really doing a patient, or whether we should consider 50 biopsies, which would be the benchmark number. We couldn't come up to it. But this is one question that we need to rethink. I think we will revisit this questions in the interest of time. We'll wait for the survey answers to come, and we might probably need to revisit here. Dealing with mosaicism, I think ma'am has really really put up quite important pointers there. And we decided that we need to prioritize the embryos. We need to define our own guidelines. So, ma'am, do you think we are at a stage where we'll be able to define our own guidelines? Or you think we are at a stage where we need to just blindly follow ASRMs and HRAs?
No. I think we are at a stage when we can actually define our own guidelines. I mean,
okay.
We should also.
So we need a separate discussion here.
Yes.
Discussion.
We need a separate discussion for the data of mosaicism from the genetic labs in India.
So I think I'll request Fiona and Ritu to kind of coordinate here, and perhaps we can, again have a small meeting, maybe a focus group discussion on how to prioritize embryos. At least we'll take experiences of people who have been doing this in the past. Do we do ET of mosaic embryos? As of yes, based on the priority scores, yes. And if we cancel cycles with no euploid embryos, yes, we do. So I think we are done with the set of questions with PGT-A. We'll move to PGTM. Over to you, Dr. Sheetal Jindal. Dr. Sheetal?
She there?
She's there, I can see her, but she seems to be muted. Dr. Sheetal?
Yeah, okay.
You need to unmute yourself. We can't hear you.
So can you see, can all of you see the slides?
Yes, we can, and we can hear you as well.
Yeah, so a very good evening to everyone. So
can you put it on full screen mode, please?
Presentation.
I think it is on. I think it is on full screen, right?
No. It's not on presentation mode. You need to put it on presentation mode. Yeah.
Is that okay? Am I audible?
I think you will have to share the window. That is the presentation. This one is on the PPTX. This one is on the PowerPoint. So you'll have to stop sharing and reshare the presentation.
Just a minute. I think there's some confusion. Sure. Just a minute, please. Yeah, is that okay?
Dr. Sheetal, you're still on the PowerPoint.
I think there is some confusion,
Yeah, I think let's go ahead because we are running short of time.
Yeah. Is that okay?
Yeah.
Yes, please.
Okay. So the topic given to me was preimplantation genetic testing for mutations, what is to be done and what to expect. So this is me, and so I would quickly start. So preimplantation genetic testing for single gene disorders, it is mainly used for single gene disorders with a known genetic mutation. And as we all know, it requires an absolute team effort, and it requires a close working between an IVF specialist, an embryologist, a geneticist, and a molecular laboratory. And appropriate genetic workup and counseling is a must before we, resort to PGTM. And appropriate case selection is very, very important before you enroll the patients into a PGT program. And usually the current practice is to do a day 5 blastocyst biopsy followed by a frozen embryo transfer. So the pillars, so if we come to what are the pillars of a successful PGT program, yes, I've already said it is a team effort. Genetic counseling is the mainstay, and counseling is required at every step once a patient is enrolled into this program. And very importantly, we require a program coordinator who can be a close link between the IVF expert, the geneticist, and the molecular laboratory where the samples are going to be sent.
Dr. Sheetal, if you're changing slides, we can't see it. I think you are on a different screen and the one which is shared is different.
Yeah, I know. There was actually some confusion with my slides today. So is there a possibility that we move to the next speaker and I can take this, my PPT, my presentation after this?
Sure, we can, if Ritu is ready.
I think there is some because I...
yeah, that should be fine. I can take up the presentation.
Yeah, let me just figure out.
Sure, thank you. Over to you, Ritu, please.
My slides are visible?
Please make it full screen.
Yeah.
Yes, you are.
Okay, so I'll be talking on PGT-SR as per my lab experience and practicing since 11 years now. So what are the balanced and unbalanced translocations? As
Ritu, your slides have disappeared.
Okay, now?
Full screen, please. Yes, now you're there.
So balanced and unbalanced translocations are, as we all are aware, that balanced are the ones which do not cause any phenotypic changes because there is no gain or loss in the chromosome number. Unbalanced, however, when people with balanced translocations reproduce, they give rise to 1% chance of the times unbalanced errors which occurs in the chromosomes involved in the translocations. So there are more severe consequences compared to balanced. Severity almost depends on the chromosomes involved and the amount of gene being involved in that. Which diseases can be caused by parental structural rearrangements? Robertsonian translocations, which involves the shorter chromosomes like 13, 14, 15 or 21 can give rise to Down syndrome, Edwards or Patau's, which are compatible with life. Reciprocal translocations, they are difficult to comment because most of them may miscarry, accounting for RPL. Some may account for RIF, and some 1% babies can be born with a disability. Inversions, microdeletions, and duplications can give rise to Williams syndrome, Prader-Willi, or Angelman, for examples. Inversions are getting pretty much common in the IVF practice. For labs, especially who have karyotyping in-house, who perform in-house karyotyping, we see the 9th chromosome being involved too much in the infertility. We also find polymorphic satellites, which I will be talking about it in my later slides. Why are we concerned about these translocations? Because genetic imbalances can be severe enough to cause embryo arrest. Sometimes some couples undergo IVF thinking that everything is normal. Some clinics do not even advise for a regular karyotype. For such couple, when IVF is being advised, their embryos go to arrest. Some may be developmentally lethal. Some get compatible with development and can cause multiple anomalies. So though the frequency is 1 in 500 in the general population for being a carrier of a balanced chromosomal rearrangement, I feel the frequency is generally 1 in 100 when it comes to IVF or an ICSI cycle. So why a routine karyotyping is essential? Karyotyping is the least diagnostic test which any IVF clinic, I think everybody should start offering a regular routine karyotyping from peripheral blood because we can get an explanation for the previous miscarriages. Some unknown carriers of the balanced translocation chromosomal couple who have not even experienced miscarriages but who are planning to get married, we can offer as a part of pre-marriage package. Information about the risk for a live-born child can be known with potentially serious anomalies if the child has a 1% unbalanced chromosome being involved. Availability of prenatal diagnosis in future pregnancy or a PGT can be offered. Now, the most important thing about any balanced translocation, especially reciprocals, are they play a hide and seek. Not all families will have a translocation which are inherited. I have seen many of them, I think most of them who are carriers of a balanced translocation, their parents are absolutely normal. So these are all de novo. So some translocations can get missed. That is why a routine karyotype is essential before a couple plans for a pregnancy. For a couple who already has pregnancy and suffer miscarriages, the scenario is different. Definitely a couple who works in a IVF setup, we should offer, the least we can do is offer a diagnostic method, KT. So most of the translocations are de novo, hence parental KT must, as I mentioned. Robertsonians may involve homologous chromosome. For example, if a 21 chromosome is involved, then the risk of getting Down syndrome is 100%. In that case, the couple have to opt for donor gametes. There is no other go. So identification of normal variants like polymorphic markers like 15th chromosome PSTK, 13th chromosome as I was mentioning, inversion 9, increase in satellite stalks, etc. can be identified. Now these polymorphic variants are seldom ignored and many laboratories do not really report that this being a normal variant, they are not reported. But I believe when I sit with the couple to counsel, most of them who are carriers of an inversion 9 or a 9QH plus or any other chromosome, they have a baby with some kind of anomaly, either autism or some kind of congenital anomaly. I mean, I'm talking about majority ones. So I think some consensus need to be taken into consideration, especially in India. We have a cytogenetic group where I'm also a member in West, and in India also we need to come up with some consensus and data about normal variants because they do cause chromosomal problems in pregnancies. I think consensus can be considering if it will be good if it can be considered for PGTA for such cases, because I have also found out if we do a PGTA for those couple, then those chromosomes apart from these normal variants are definitely involved in aneuploidy. So cytogenetic and molecular evaluation even for the product of conceptus is very, very important. I believe it has to be done even if it is first time loss because we can know the silent carriers of translocations. If it is for other chromosomes involved, we can always tell them it's a chance event. So balanced translocation detection can be missed. Patients can be unaware of the carrier status until they reproduce and suffer RPL. Some patients suffer one RPL, have a healthy child, and then suffer series of RPL and remain undiagnosed. There are many of such category couple where they have one live baby who is healthy. They think they are absolutely normal, and why are they suffering so many RPLs? That time, if we offer karyotyping, we come across them being either one of them being a carrier. And some couple may seek IVF and have recurrent IVF failures. Now when I talk about RIF and RPL for chromosomal translocations, in reciprocal translocations you see lot of RIF category of patients, and RPL comprises mostly for Robertsonians or the ones which are compatible for life. Few of them when undergoing PGTA do randomly get diagnosed being carriers of a balanced or a raw translocations. So I'll be coming and showing you how different cases I have been putting on, and these examples have been put on. So this is my data from 2013 to 22, where we could see 43 couples with previous natural pregnancies and 62 no natural pregnancies. Out of them, 94 pregnancies happened, and these 94 pregnancies, only 8 were healthy children. So what happened to the remaining ones? 75 miscarriages were there, only 10 live births. In that, only 6 normal karyotype children were born, which were 2 balanced and 2 with severe malformations. So this is a call which tells us that PGT-SR should be advised for RPL category or RF category, especially RPL category couple. And there were 9 therapeutic abortions. Now this data for reciprocal translocations involved 201 couples from 2020 to 22. 109 couples had previous natural pregnancies, 92 had no natural conceptions. So these were under the RIF category. Out of this, only 12 healthy children were born and rest ended up in miscarriage or abortions. So male translocation carrier PGT-SR results with the males, we are privileged to test for single sperm haplotyping. How it helps is it determines if a male is a carrier of any balanced translocation or a Robertsonian translocation. We can collect sperms and then do a single cell haplotyping or an aneuploidy testing to rule out, to tell us how many embryos are actually needed for a PGT cycle. This would help clinician and geneticists to determine the correct number, and at least after testing, patients would have 2 or 3 numbers for transfer. So out of that, we had 16% of unbalanced gametes. After PGT-SR on these embryos, only 32% were transferable embryos and rest all were aneuploid, which consisted of unbalanced aneuploid as well. For the PGT-SR results for reciprocal translocation, we tested around 2000 cells where 63% higher number had unbalanced gametes and only 13% of them had transferable embryos. So this data actually calls out for a PGT-SR which is highly indicated in certain group of patients. Female translocation carriers, only 19% were transferable embryos, out of which we had pregnancy rate of around, CPR rate of around 65% for both Robertsonian and reciprocal in RIF and RPL group. And the final outcome, we had live birth 64%, and then beta negative for few, and then ET cancel for few, because for few patients, all the embryos were aneuploid. Now, this is an interesting case when this couple came to me with a series of miscarriages, some IVF failures, some natural IUI failures. The couple was getting pregnant, but they were ending up in IVF failures, IUI failures. When I happened to advise a karyotype, both the couple interestingly had balanced translocation. As you can see in the karyotype, female had 10 and 16 translocation and male had 9 and 14. They were non-consanguineous couple. This is the pedigree I have taken as per the family history. They were non-consanguineous, and then but the female side had no family history. The female side it was de novo. Male side it was a familial translocation. Hence, in the beginning of my talk, I said some translocations can be familial and some can be de novo. So they ended up in spontaneous abortion, and they had a carrier child as well. So this is the PGT-SR results for this case, where 2 embryos were found to be normal and balanced. I'm in the process of developing a haplotyping linkage-based analysis for PGT-SR in my lab, similar to PGTM, where I can actually report an embryo can be balanced or normal. So now no technology can actually differentiate between normal and balanced. Other than karyo mapping, NGS is now being developed to differentiate between these two. So for this case, only 1 embryo is abnormal and the other 2 are balanced and normal. This is another case. You can see the patient message while I was counseling them. They had revealed her being advanced maternal age 40 plus and had 2 miscarriages before, both the pregnancies following IUI and natural. Thereafter, they have undergone some IVF in Northeast and had 3 IVF failures, but none of the clinic advised for a normal karyotyping. They just kept on doing series of IVF, but all ended up in failures. But then when I advised the couple a karyotype, couple had a 9QH plus, which is a normal variant in the female karyotype, and the husband had a translocation between chromosome 12 and chromosome 3. You can see the breakpoints here. Now, these breakpoints are very small to be detected on NGS. I'll be talking about it in my latest slide because I don't want to get too much technical. So these translocations were actually kind of causing recurrent pregnancy loss both and RIF as well. So these are some of the karyotypes which are dealt in my lab for PGT-SR. I couldn't put all of them. You can see the first karyotype here, chromosome 1 is actually broken into 2 parts and chromosome 21 is attached to chromosome 1 here. So this was a very difficult translocation for me to handle. But then fortunately, since I worked with Deepak very closely to develop a FISH protocol in my lab based PGT, day 3, the only drawback is we use day 3 based embryos. But then I vouch on day 3 as well that fish work wonders. It's not that NGS can sort out everything. Sometimes we geneticists have to work closely with the case, with the clinician, and define a technology where the best can be offered for the patient. In this case, actually, I used the fish technique where I could define the breakpoints very well and achieve a successful pregnancy for the patient. This is a case of a Robertsonian translocation. The most interesting thing about it is, apart from picking up the different 13, 14 trisomies or monosomies, we can also pick up segmental ploidies, which is trisomy 19 in this case. So the advantage of doing an NGS in advanced maternal age, fine, it is good because it can screen all the chromosomes. Technology involved definitely a fish. As per my personal experience, I offer it for translocation group of patients who are directly having RPL. That is, we know the cause of their pregnancy getting failed. That is because of these chromosome involvement. I would ask them to undergo a fish. POC tested positive with unbalanced aneuploidies or trisomies or monosomy. Patients with advanced maternal age or patients with a history of compatible aneuploidy child can get fish done. Now these are for the group of patients whose embryo do not develop to blastocyst. So we don't want to cancel a cycle just because embryos do not go to blast. There are some translocations which causes embryonic arrest at certain stages of embryonic development. So we should know the reason why it is happening. So for some category of patients, fish can be beneficial. History, then CPR rates were good for such indicated cases. That is why I feel fish can be best. NGS, advanced age involving translocations where there is a need of screening all the chromosomes. That is CCS, comprehensive chromosome screening gets must. For such cases, I think NGS would be beneficial. Where there is a male factor involvement and a female also there with a translocation, we need to test more number of embryos. In that case, NGS would be beneficial because fish is for day 3 embryos. You cannot end up in testing 20 or 25 embryos. So let those embryos reach blast. So basically the geneticist has to decide depending on the detection limit as per the breakpoints involved, because NGS has also got limitation. We have detected up to 2 MB breakpoint detection in NGS, but less than 2 MB cannot be detected on NGS. Fish versus NGS, this is my lab data where we could report 57% and NGS was 43%. So mostly we have done more number of cases on fish as well. Coming to polymorphic variants and inversions, as I've already discussed, it can cause multiple anomalies in children born out of a carrier couple. Chances of abnormal gametes due to recombination gets more because I have seen the data. Unfortunately, I couldn't present my PGTA data here. But for the couple whom we have advised with an inversion line or a 9QH+, we have seen mostly aneuploidies involving chromosome 9 and chromosome 16 in such cases. So this was one of the case where a patient had a 9QH+, and you can see the results here, all the chromosomes, all the embryos being aneuploid. This was a case where we had to cancel the ET. When the patient undergone a different cycle with a different fresh oocyte pickup, everything, a fresh cycle, second time also this patient had all abnormal embryos. So I wanted to add on in the consensus that some patients may prone to be or susceptible to having aneuploid embryos. Such cases definitely we have to do PGT and then only we would know. So this was an RIF case with a balanced translocation where this patient was unaware of the balanced translocation status. When we did a PGTA, generally in my lab I do a high resolution based PGTA because we have couple coming from Middle East also. So and we have a good male infertility workup here. So when we do PGTA, it's for high resolution based. This patient male had a translocation between chromosome 1 and 20 and he had a vision problem. When we did an NGS testing, his whole exome came out to be normal. But when we did a karyotype, his karyotype status was not known to us. His first cycle when we did, we came to know that his embryos are, one is trisomy 1, one is trisomy 1 and monosomy 20. So trisomy 1 is actually occurred twice. That gave me a doubt, and then I asked for a couple karyotype. And then interestingly, we found out that he is having the problem. So this is how some patients can be unaware of their status. So male factors shouldn't be ignored. RCP can cause male infertility and female RPL. Reciprocal translocations can cause male infertility. Males and females, there can be different responses to meiotic disturbances. This is what I have seen as per my data. In spermatogenesis, meiosis is generally arrested and apoptosis occurs. In oogenesis, meiosis is not halted and thus RPL can occur. So quality of sperm do not affect fertilization rate, cleavage rate and blastocyst formation. So that is why when there is a male with some kind of translocation, you can expect good number of blastocysts, but the only problem is the spermatogenesis gets disturbed when they are carriers of some kind of translocation. This is seen for majority of the males who carry the translocations. From the IVF point of view, I feel embryoscope is very, very important. Whoever is doing, whichever Indian clinic or hospital is doing a PGT, they should have an embryoscope for all their patients, especially for recruited for PGT, because it will determine the number of embryos getting arrested. Some patients, some translocations behave differently in each and every one. So for some translocation patients, there are possibilities that embryos can get arrested. They do not develop to day 5 or some develop to day 5. So at least we have an answer. We can counsel the patient next time to attain these many number of embryos optimum for PGT testing, and then we can give some normals to them. Embryo accumulation is very, very important in cases where there is a female translocation involved, because we have seen there are a lot of DORs, diminished ovarian reserve patients who have specific translocation and they are quite young. In some cases, embryo accumulation is very important. Segmental aneuploidies also occur in translocation group of patients. Hence, for such group of patients, doing an NGS would be better. In cases of male infertility, optimum embryos may suffice. More OCR cycles are required in patients, as I said, for adequate numbers. One of the advantages of doing day 3 FISH technology is the availability of more number of embryos available for testing for PGTS. This is one of the case where parental KT was normal and baby was born twice. They have 2 babies born with dysmorphism, seizures, brain atrophy, rock-bottom food and developmental delay. They were counseled for PGT-SR because their FISH result of one of the babies showed 2 abnormal copies of chromosome 1P and XP. So this is a chromosome microarray result where you can see trisomy 1Q. And the 4th chromosome has a monosomy. This is interesting because the parental karyotype was absolutely normal. They had the baby twice born with it. This patient is actually recruited for PGT-SR, and I am yet to see the results. So points to conclude: high resolution NGS to be performed depending on detection of partial aneuploidies and duplications. Mosaicism pipeline has to be well defined. PGT-SR definitely benefits both RPL and NIF group of patients. Male translocation carriers may exhibit azoospermia, but blastocyst rate is independent of the translocations involved. Mitotic errors need to be carefully analyzed to rule out mosaics. So this is my confidence of obtaining and talking about PGT from past 11 years. I hereby conclude my talk. Thank you.
Thank you so much, Ritu, for the wonderful comprehensive overview of PGT-SR. And I think there are very, very few labs in the country who actually offer a good quality PGT-SR. And we are happy to listen to this program that, yes, in this country, we have the possibility of doing PGT-SR. And I think all those who are listening, please do contact Ritu in case you have such patients. And from the laboratory side, at least we as geneticists always tell that please put all your infertile couples for a karyotyping, basically, because it can change the way you are approaching your patients. I presume Dr. Sheetal Jindal will be ready. In the interest of time, I will not run through all the questions like we did for PGTA, but let's have a quick run for PGT-SR if there are any specific requirements. So based on Ritu's talk and some previous discussions, indications for PGT-SR, obviously it is abnormal karyotype with a balance or a Robertsonian translocation. But Ritu, as I understand correctly, you suggest that if it is a RPL or a RIF, you must consider doing a karyotyping because there's a high likelihood. I'm very interested in this answer if you get variants, because this is one question that perpetually hits us as geneticists always. that, I have a patient with a variant, and most of the times they say that variant is, not to be bothered about. But as I get from your talk, you do insist on doing a PGT-SR for a variant. Did I get it correctly? A very short answer, please.
Yeah, so you're talking about variants, right?
Yes.
Yes.
Yeah, I believe variants shouldn't be ignored because in my career, I have seen the variant couples who are carriers, they have either had RPL more than 3 times or have a multiple anomaly baby. So I believe doing a PGT-SR would be helpful.
And in the variants, when you have done a PGT-SR, do you think that there were more number of aneuploid embryos?
Yes, especially I couldn't do for all of them because it is a choice of patient.
Absolutely.
The ones involving inversion 9 and 9QH plus, I have seen trisomies of chromosome 9 and monosomy of chromosome 16.
So that will be great if you can publish this data, at least put it up on the public domain so that this information can be used to set up the guidelines. And I also got this interesting case, the last which you kind of put it up, that there was a previous history where there was some issue with the abortion or the baby which was born out, and there is possibility of a hidden gonadal translocation or aneuploidy. So in such cases where if there is a previous history, we should consider them for PGTA or PGT-SR, right?
Yes.
Fiona, you had a question.
Yes, I would like to just add to what Dr. Ritu was talking about. So even I have observed significant incidence of aneuploidies in patients carrying polymorphic segments, especially with inversion 9, inversion Y, which are very common, as well as satellite regions on any other chromosomes have a tendency to have more than 3 miscarriages, RPL, or it is a significant impact on the aneuploidy. It's ranging between 60 to 80% is what our data is showing as well.
So I would request both Ritu and Fiona, and if there's anybody else listening out here, if you have real life data from your own clinics or your own experience on carrier couples having variants and their aneuploidy outcomes in the embryos, it will be nice if we compare it with a non-carrier couple with a carrier couple and show that there is an increased incidence that justifies the case, because this is a hell lot of a confusion. I remember a discussion with Dr. Jindal, Dr. Umesh Jindal in one of the meetings, and she did ask me that, what to do with the variants. We get so many patients with variants and we often don't know what to do. So I think this is the right platform there. I think the minimal workup needed for there was a question?
I think sperm fish is, I believe it is mandatory, especially for translocation carriers.
Fiona, would you want to comment on this?
Yeah, in cases of translocation carriers, what spermfish will do is give us an idea of the dosage of aneuploidy, but right now the challenge is there's no formal cutoff that has been developed anywhere. So the interpretation is a challenge. Of course, at the end, the sperm that we are going to select for fertilization is something that we will not know what is its karyotype. So when we are doing PGT-SR in embryos, it will inevitably factor in that, I believe.
Fantastic. So I think we may consider it is advisable to do a PGT-S, sperm fish, if there is a male factor translocation. And choice of techniques, as I get from Ritu, NGS is obviously your primary choice, high resolution NGS, but you do suggest that there is a role of fish, especially if there are fewer blastocysts available in the case. Okay, great. This is fantastic. I think we can move ahead with the next slide. I think risk assessments and all that, I think that stands common for both. Both the clinicians and the genetic counselors must be involved. External lab or in-house lab, it shouldn't matter. It should be in consultation with the lab. Minimum number of embryos, I think, Ritu, you will perhaps have some number in your mind, which you think, you said, you definitely kept on saying that we need more embryos, more embryos. What's that number, magic number for you?
Okay, for reciprocal translocation females, minimum number would be 8.
Wow.
Yeah.
For Robertsonian translocation females, the minimum number should be 10 to 12, I believe. And in case males are carriers, the number can be compromised to 5 to 6 because males have enough sperms.
Male carriers, 5 to 6. So I'll rather than dividing Robertsonian and reciprocal separately, we will say 8 to 12 is a number that you would want, and in that case, we need to do these kinds of things.
So these are blastocysts, not day 3.
Okay, blast.
I have a question here. What if you repeat 2 cycles and you get only 4 embryos over the patient or not? Sometimes, most of the translocation cases I see, we hardly get 2 to 3 embryos, and patients may not really be willing for more than 2 IVF cycles. So, developing a minimum number is difficult, but as Dr. Ritu said, an ideal number would be in the range that she has described, but it's difficult to define minimum.
Yeah, so Fiona, I get it that, at the end of it, it's patient and clinician's decision to do the whole thing. But as a guideline for people that somebody cannot start with a SR program saying that, oh, I have 2 embryos. So your primary recommendation would be 8 to 12. So at least the reader is kind of mentally prepared that, I'll have to pool a number of cycles to do this program. I think that makes sense, right? If anybody has a different point, please put in the chat box or please raise your hands. I think the rest of it remains the same, and I think revalidation. So Ritu, if there is a patient, and this also applies to Fiona, both of you, that if there's already a couple or a patient recommended to you for a SR where the karyotype is done elsewhere, do you recommend doing it in your own lab first, or you think it's okay and just start up from there?
I think most of them we have done in-house and we could do it. Some who have done karyotyping outside, we have repeated the karyotype, although I have not revalidated for PGTS.
Okay. Fiona, do you think you consider it, or you think no, you go by the report and just go ahead?
It's optional, yeah. We can go by the report and go it because there isn't much structural changes that will come from lab to lab.
But then breakpoints are very, very essential, as you know, because NGS has limitations to 2 MV, though theoretically they say up to 6 MV. We could detect up to 2 MV, but breakpoints are very, very essential. And if there are very minute changes or deletions, I think FISH is the gold standard.
I think, yes, it's important to, as she said, to see the location of the breakpoints. If they are very small telomeric breakpoints, it's literally impossible to get them mapped on the NGS because telomeric regions are not mapped as well as we expect them to be. So in such cases, FISH is a test of choice.
Fantastic. So I think when you're talking about applying FISH, at least you would recommend that you redo the karyotype and revalidate it in your lab. Great, fantastic. If Dr. Sheetal Jindal is ready, can we start a presentation, please? I'll have to stop mine sharing. Okay, this is stop. Dr. Sheetal, are we ready? Dr. Sheetal? We can't hear you.
Yeah. We can't hear you.
I think it's been a bad day for Dr. Sheetal because just before the webinar, the talk started and she lost a presentation.
Oh.
Yeah, so she had to redo a bunch of things.
Oh my God.
Am I audible now?
Who's she calling? Yes.
Thankfully, I don't know what is happening. There is, because of that Amrit Pal, there is a big glitch, and there is.
Oh.
So please, I can't share my content. Someone has to allow me.
I will make you the co-host.
Co-host, yeah.
Yes, I think you can share now.
Okay. So I can't share the content again.
Not yet?
Not yet.
Ouch. Oh, God.
Someone else probably help ma'am in presenting while she talks.
But can you, Sheetal, can you send me the presentation on WhatsApp?
Okay, I will just send you.
Yeah, so
or email it,
whatever. Share their mail ID or something,
Yeah, it's drsailikandari@gmail.com, just my name.
Or you can send it to me or Sally, anyone.
Yeah, so send it on WhatsApp or send it on my email, drsailikandari@gmail.com.
Oh, just a minute. S-A-Y.
Yeah, it's the name on my this thing. Dr. Saili Kandari, DRSAYALI.
Kandari, Kandari, right?
Yes, Kandari@gmail.com.
I'm so sorry for this confusion.
Just send it right now. Let's figure it out.
I'm sending it.
Yeah,
it's okay. This is very much a part of webinars now. We have all got used to it. We all had a fair share of glitches and issues.
There was, yeah,
5 minutes.
lots and lots of stuff.
Deepak, I will try sharing from my desktop. Her
Yes,
presentation
that should be, yeah, that should be okay, please.
just make me.
If she, so Dr. Gunashala has her
Okay.
PPT.
There's one more computer by the name of Sheetal Jindal only, co-host.
Yes, I have met the co-host
I'll
again.
try from here if
Sally, I've mailed you, Sally.
Okay, I'm just.
But if Dr. Umesh can share it from that also, I've made the co-host that
I know there was some problem with that computer too. I was sitting over there just to deliver my talk, but then
okay, that's there. We are there. We are there. We are there.
Is it
got it.
visible?
We got it.
Yes, yes, yes.
Yeah,
we are.
it's
We can
visible.
start.
Sheetal, you are there. I can move on.
Yeah, I got the email too.
नहीं आ रहा नहीं हो रहा वो उनको करने दो.
See, I'm projecting.
It's not happening. Yeah, I downloaded your PPT.
Sheetal, can you see the slides?
Yes, I can see. So I'm just
start then. Start.
Yeah. I'm so sorry for this delay. So quickly, I would just so next slide, please. So next slide. So I think I just gave the introduction, and the PGTM has to be a team effort between an IVF specialist, embryologist, geneticist, and the molecular laboratory. And we have to have an appropriate genetic workup before we actually enroll any patient into the PGTM program. And that is where the role of the geneticist and the genetic counselor lies. So these days, we have all moved to day 5 blastocyst biopsy because of the reason being that it gives us more number of cells as compared to a day 3 embryo, and followed by a frozen embryo transfer. Next slide. So it has to be a close association between a geneticist and IVF expert and the genetic counselor, and we definitely need a program coordinator who is able to communicate with all three, and so therefore and help in the smooth functioning of the program. Next slide. So I would not, so this was just a slide. So there are a lot of prerequisites before we set up a PGT program. And so this slide I took from this HFEA, but then yes, a lot of things are valid in Indian context also. So I would not just go into the details of it, but this is just to show that, setting up a PGT program requires all this. It requires equipment in the form of laser. We have to have adequate lab facilities. Yes, training, biopsy, good blastulation, and definitely a good courier service, that is, and appropriate SOPs in the lab, and definitely the cost, good freezing. All this is part and parcel of the PGT program. Next slide. So yes, so before you enroll the patients into PGTM, there has to be an appropriate patient selection, and it is only possible when there is a genetic diagnosis which is technically feasible, and the reliability of the genetic diagnosis is high. You also have to consider the feasibility of the IVF, and a lot of times you might end up in pooling the embryos so that you get more number of blasts and maybe higher number of unaffected embryos. And definitely you have to take a lot of times the couple who is coming to us with seeking PGTM due to their genetic problems, they might themselves be suffering from various health problems, and from that perspective you have to look at the patient's health so that before you enroll them into the PGT program. Like I had one male with severe myotonic dystrophy, and he started having masturbation problems, and it was very, very difficult for him to give his semen sample, and that is what and he had subsequently become oligozoospermic as well. So all these problems can definitely occur if you are taking these patients. Next slide. So, I just want to start by enumerating two cases. So it is not necessary that every patient having a genetic problem would, can be enrolled into this PGTM for mutation testing. Like there are a lot of times when we feel that the genetic diagnosis is feasible, but then still the couple has to resort to different methods of getting a pregnancy in the form of maybe an ovum donation or an IV or an adoption. So this was one patient who came to us. She was 36 years old, female, and was a carrier of DMD mutation herself. Her two sons had already died of DMD. And so her genetic analysis, by NGS was suggestive of a point mutation in the DMD gene. And she came to us seeking IVF with PGTM. But on evaluation, I found her AMH to be almost like 1 nanogram per ml, and her antral follicle count was just 3 to 4. It was barely 3 to 4. So pulling up and all was not possible for this patient. So I advised them that it would be better for you. She was already 36, 37 years. So I advised her that, in view of average ovarian reserve, probably, you might not be able to, we might not be able to successfully apply the mutation testing because we might not end up getting those many number of embryos. So we advised her IVF with ovum donation, and she did conceive and took a baby back home happily. So there was another interesting case. She was a 32 years old female, and she was a carrier of Fragile X mutation. So her first child was affected by Fragile X. First male was affected by Fragile X, and there were more than 200 CGA repeats, and he was mentally subnormal. So in the second pregnancy, we definitely did the amniocentesis for the Fragile X, and the baby was unaffected. But what happened later? The baby developed IUGR and died in utero. So the whole exome sequencing of the fetus showed vows for GNAS gene, and there was a heterozygous missense mutation for the biotinidase and CFTR gene. And subsequently, when we did the sequencing of the parents, they both were carriers of BTD gene. So the couple agreed for a PGTM, IVF with PGTM, and then subsequently they thought that it is going to be very expensive. They opted for IVF with the ovum donation. So now once we screened the donor for the Fragile X and the BTD gene, and subsequently the donor was also found to be a heterozygous carrier for some Usher syndrome. And again the husband had to be tested for the same gene which the donor was carrying, and ultimately the couple did undergo, now she's currently planning up with this IVF ovum donation cycle. What I want to point out is a lot of times, yes, we know that PGTM can be done for 2 or 3 disorders which can be there in the couples, but still going through so much of testing again and again and again, and this donor also initially she ran in between. She's because we were taking so many blood tests on her. So these are a lot of practical issues which do occur. And what happened after the second baby, while we were testing for the whole exome, I didn't mention it, but then she again conceived, and the third baby also was ultimately, the third conception which happened, and that was unfortunately Fragile X positive. So these complications do occur once you are running a PGT program. So it's not easy. A lot of times, and changing the gamete becomes quite an easy option for the couples because it involves lesser of time, it involves less of money, and maybe an easier way out for them. Next slide. So what is peculiar about PGT counseling? PGT is something, it makes our medicine predictive. And yes, there are a lot of people who claim that, the embryo also has a right to be born healthy. So it gives, how it is making medicine predictive, that it gives the patients a chance to choose as to what type of, choose their genetic risks and, subsequently, decide on their future pregnancy. Next slide. So now this brings me to the indications of doing PGTM. Yes, PGTM is indicated for most of the single gene disorders where the genetic diagnosis is known before. So couples who have a family history of lethal X-linked disorder in males, we have a known alteration in any X-linked gene, and if we have carriers of autosomal recessive conditions or in any autosomal dominant disorders, and if we have a family history of a genetic defect for late onset autosomal dominant disorder, and if we so these are probably all single gene Mendelian inheritance. In most of them, PGTM is possible. Yes, for hereditary familial cancers like breast cancer, BRCA1 and BRCA2, triplet repeat disorders, like fragile eggs, and definitely for HLA typing to find a matched donor in cases of thalassemias. So these are few of the common indications for which PGTM is currently being done. So this was the data published by ISHRE PGT Consortium, and these were the major disorders, for which PGT has been performed. And this data is from 2016 to 2017. Amongst this, Huntington disease followed by cystic fibrosis, this neurofibromatosis type 1. So this is so these are the few of the indications for which the world over PGT has been performed most commonly. Next slide. So now coming to the components of PGT cycle and time frame. Yes, an initial. So you require 3 to 4 visits with the geneticist or the genetic counselor just to establish your genetic diagnosis, and followed by a pre-PGT workup, which usually requires approximately 8 to 10 weeks, and followed by, once you have the pre-PGT workup in your hand, then an IVF cycle would require probably a month or so. And then after that, you biopsy the embryos, and yes, after that, it's another 1.5 months of time, which is required for the lab to give the result for the embryos, and then a frozen embryo transfer has to be planned. So a full PGT-M cycle definitely involves a minimum of at least 6 months, and if embryo pooling is there, then this can get extended even longer. So this is the time frame we are looking at, and this is a very important part of the PGTM counseling, which we have to do. Next slide. So yes, once the geneticist consultation, genetic counseling is a very, very important aspect. It has to be non-directive. And we have to talk to the couple. It's not just that most of the times you see there is any genetic disorder, it is an autosomal recessive, and the couple can get naturally pregnant. You always give them the option of IVF with PGT-M. A lot of times, I think the option of spontaneous conception followed by a prenatal diagnostic testing might be an easier option. Sometimes, we have to discuss about altered, like for gamete change. All these options should be discussed with the patient. And one thing very important is we really need to empathize with them, and they are in a very different frame of mind. A lot of times one child is enough for them to think, and they would just say that, okay, we don't want a baby. So you have to slowly open their mind and just tell them, yes, there is something of this, there is a technique which is available, and now it is quite successful. And yes, the feasibility of the IVF and contraception in the waiting period is very, very important, because a lot of times these patients end up, they conceive in between, and that makes things worse for them. And yes, it's a good idea to give them all the written information in hand. Next slide. Yes, and IVF, so the feasibility of IVF as a clinician, this is something which is also very, very important. Our aim should be to maximize the oocyte retrieval. We should enroll into PGTM only and only if we are, we are making good blastocysts. So I was attending this PGTIS in Bangkok, and Dr. Don Lay was very, very clear. I heard him saying we should only and only attempt PGT if you are if your blastocysts are excellent. Otherwise, and you are, and if otherwise, you might end up, the patient might end up spending lots and lots of money, and you might be, it might not be of any help. You might be actually ruining their time, money, and energy. So, so this is very, very important. The clinician should be well versed with IVF. You have to, maximize oocyte retrieval, but at the same time minimize the risk of ovarian hyperstimulation syndrome. And pooling of oocytes a lot of times is required. And you have to, as far as embryos is concerned, in spite of this is one of the limitation. In spite of having good number of embryos, you might not have even a single embryo for, to transfer. So it might be that all the embryos are affected, and then the patient is back to square one. So this is something which is very, very important. And yes, you have to discuss about frozen embryo transfer, and that the overall success rate is not 100% in spite of, doing a good embryo, a good endometrium, but still a normal embryo, a genetically normal embryo, there the results can be negative. So this becomes sometimes very, very tricky. And, after all, the overall success rate with whatever said and done is 50%, which means every second patient undergoing IVF, with PGT, we might increase it, but then, it is not more than 60%. So this is something which is very, very important, which we need to discuss with the patients. Next slide. And yes, one of the most important aspects of PGTM is pre-PGT workup. Usually pre-PGT workup is something, it is like that you design a test for this, you design a test for the, for the patient and the entire family. So for this pre-PGT workup, probably the whole of the couple's extended family also gets involved. And you have, it is just to, and the aim of this pre-PGT workup is to be accurate in testing the mutation. So usually it requires a 3-generation pedigree, and short tandem repeat marker correlation is something which is most commonly practiced, along with some SNP-based markers. And definitely this linkage analysis is very, very important because it improves the diagnostic accuracy of the whole PGTM program. Next slide. So something which is very, very important. So a lot of times, this is how I have corrected myself. I have a lot of times I have, I seek from the lab saying, okay, so this couple is, one of the partners is suffering from autosomal dominant polycystic kidney disease. So is PGTM possible? But yes, we have to just reframe. So the most important way in which we say this is, can we do PGTM for this family? Because PGTM is, is done via linkage analysis. It is not just direct mutation analysis, and this is very important. So it improves so a lot of times, just because of this limitation, if the family members are not involved, we might not be able to, even if we have the genetic diagnosis in hand, we might not be able to, do the PGT for the patient, for the couple. Next slide. So what is linkage-based testing? So PGT involves trophoectoderm biopsy, which is most of the embryos which are able to reach day 5 or day 6, and some IVF centers do it on day 7 also. So so linkage-based testing has to be done because a trophoectoderm biopsy varies in size, but usually we are able to get, so even if it is an expanded blastocyst, at the most we are able to get just 5 to 7 cells. And these 5 to 7 cells are not able to give us enough of DNA. And so we need to really amplify this DNA so that we can make some conclusive results out of it. And this amplification of, even if how much ever good the labs are, but the problem of allele dropout can definitely, crop in, and which can interfere with our results. So that is, so linkage-based testing is something which can, which just helps us in overcoming this problem of allele dropout. So we, how do we do this is, there are short tandem repeats which are present upstream and downstream the region of the gene of interest. And these, so you with the haplotyping and this short tandem repeats, we are able to more accurately able to pinpoint as to which is the affected haplotype, and it will just help us in the presence or absence will help us in being more accurate in the diagnosis of the affected allele. And so direct mutation analysis, and definitely, direct mutation analysis sometimes is not required and might not be included in the test design of the PGTM in case we have good STR marker. If a good STR marker, linkage analysis is possible. Next slide. So I just thought, I would just, give this example how this allele dropout works. So this is something, so I just want to say that there is a genetic phase which is, established while we are doing this PGTM. So which means that you require at least 2 generation, up the couple, often above the couple who is seeking this PGTM. So it is just to establish, the correct, just to establish just for the pre-PGT workup. So, and once this genetic phase is established, then, with the help of linkage analysis, we are able to, take care of this problem of allele dropout. So in this scenario, let's say we have a couple. So these are the, so this red is the affected allele, and this blue one is not, is the normal allele, is the wild type of allele. So let's say if we are doing it without the linkage analysis, if there is an accurate amplification of the mutation site, we know that, so this is the affected one, and this embryo is affected, and yes, we will not be able to, we should not transfer it. But without the linkage analysis, if this allele drops out, then the embryo is affected, but it can be diagnosed as normal. So with linkage analysis, with STR markers up and down, if there is accurate amplification at both the sites, then we can very easily pick up. But if this allele dropout occurs at the mutation site, still we know with the help of STR markers, yes, that, this haplotype is so this is the affected haplotype. Even if the allele dropout occurs, we can, diagnose it as an affected, and we diagnose it that it is an affected embryo, and maybe, it will improve the diagnostic accuracy. So which is the next slide. So there are a lot of times, the family members are not available, because of some other reason, sometimes they are affected and they would have died. And a lot of times the couples don't want to involve their family members. Or if the, patient is affected with any de novo variant, a lot of times it happens 10% of the cases of autosomal dominant polycystic kidney disease. We are not able to get the, it could be a de novo variant. In such cases, yes, PGTM is possible in some of the cases without the family members. And it utilizes the way to do it. Next slide, please. So in such scenarios, let's say we have this, so this is an autosomal dominant disorder where we are, discussing, and this is the patient, and this is the allele type which is there. So this patient is having the alleles as B and C. So if we are making, and we do not have any parents, from here where we can get the haplotyping or the STR markers. So only this, so what we do is we can, if the parents or family members are not there, let's say we do the IVF, we get multiple embryos, and let's say these are the, various embryos, which the couple is, the various embryos which are there. And we know that, and we can see that this C, the shaded ones are the embryos which are affected, and the B are the ones which are not affected. Now, if we see that the C is the one, which is, C embryos are the one, C allele is the one which is being carried, and this is the one which is being affected. So through them, so any STR markers which are coming from through the C allele, it can just give us a rough idea as to, that is the point where, which is the affected allele. So next slide. So PGTM is possible via exclusion testing also. A lot of times, there are cases in which non-disclosure has to be done. I mean, the parent, the intending couple who is there, they do not want to know their disease status. And in that scenario, the lab doesn't know who is affected, or even the patient doesn't know who is affected. But yes, through linkage analysis, PGTM is possible. And for more multiple disorders in the family also, we can do a pre-PGT workup accurately. A lot of times we get VOWs, variants of unknown significance. So, and if we do a proper documentation of the pathogenicity and through proper patient counseling, yes, we can do a pre-PGT workup properly. And in such scenarios also, PGTM is possible. Next slide, please. So, and yes, a lot of times, because of the limited amount of DNA which we get, so, if it is a large deletion and duplication like the one which occurs in DMD, we might not be able to sequence the actual disease in question. And in such scenarios, this linkage analysis really helps. So the type of mutation, or in a lot of times complex molecular rearrangements also, the linkage analysis helps. Next slide. So, just to summarize, so these are the various types of techniques which are available, it can be either a targeted amplification or whole genome amplification, and followed by targeted amplification. The various modalities which are used it depends whether the lab we are pursuing PGTM or PGTM along with PGTA, and accordingly it can be just a targeted amplification. The most commonly used technology is multiplex PCR, in which it can be either the genetic markers or the pathogenic variants, which are most commonly tested. Depending on the disease in question, the genetic diagnosis is established, and the pre-PGT workup, pre-PGT test is made. Next slide. So, I've just brought two cases, just to, I had discussed these cases before also, but just to give a idea of as to how a PGTM is done. So this was a patient who had come to me at 33 years of age and she was a carrier of DMD gene mutation. Her brother had died of DMD, and she had one mid-trimester MTP, in which DMD was detected after amniocentesis. She did have her brother's records, which had given us a definitive diagnosis of DMD. Her CPK levels were very, very high, and he had typically at a very young age had developed calf hypertrophy and difficulty in climbing the stairs. And already and once the MTP was done, the record of the fetus had shown exon 43 duplication. So this was the pedigree. So this was my patient, and yes, her brother had died of DMD, and and the fetus had also died, and she was herself a carrier. So with this genetic diagnosis in hand, she had approached us. Next slide. So this is the report of the affected fetus by MLPA. We can see the duplication over here. Next slide, please. And she had a good ovarian reserve, and she was very clear that she does not want to go through the turmoil of abortion. And karyotype was done, and for both the partners, karyotype was absolutely normal. Next slide. And this pre-PGT workup we had involved, because DMD is a bigger gene, so we fortunately she had both her parents with her, father and mother. So it was done through haplotyping using STR markers, and the counseling was done that only the known genetic disease will be tested, and if there is any de novo mutation, that would be missed. Yes, next slide. So this was the pre-PGT workup. So we could get approximately all the markers in this patient were fully informative, which means that we had a good pre-PGT workup in our hands. Next slide. And this was the IVF stimulation, which we did. Next slide. So we made 7 good blastocysts and we had biopsied all of them. Next slide. And this was, we were lucky enough to get 5 low risk embryos, as you can see. And out of them, 1 was non-inflammative and 1 was at risk. Next slide. So I did a single blastocyst transfer for her in a modified natural cycle, thinking that she's a fertile patient, and the result was negative. Second cycle I did, in a replacement, and it was again a single blast transfer, and again the result was negative. I've written awaited. I'm sorry, I just didn't change it, and it was again negative. So I did a third cycle for her, and this time I transferred the 2 normal embryos, and luckily she conceived with a single, she implanted a single one, and currently her pregnancy is going on till 12 weeks, and her prenatal screening and all has been normal till now. Her ultrasound scans have been normal. So she's just waiting for the amniocentesis, which we'll be doing at around 16 weeks, and probably it should be, let's see what happens. It should be okay for her. And along with the amniocentesis, definitely we'll be doing a QF-PCR for the common chromosomal aneuploidies. Next slide. So yes, this is another case, of non-disclosure. So she was a 32 years old female married for 4.5 years. Husband's mother was a known case of autosomal dominant adult onset leukodystrophy, and mother's report was unavailable. The mother had died, but then her report was unavailable. So this is what we were suspecting. And her father was unaffected. Mother had autonomic symptoms at 40 years with this R3, and she had died due to aspiration pneumonitis. So they were quite a learned couple, and they came to us for preconception genetic counseling. And the husband didn't want to know her career status because he was afraid that if he is affected, then he wanted to be away from it. And next slide, please. And so this is the pedigree of the husband, and husband's brother had some genetic report, but that was not available to us. Husband's mother was affected, and then and her father, the mother's father was also affected. But then we didn't have this report. And then in the third generation, there was some family member who was having this LNMB1 duplication. So we traced that report from the US. Next slide, please. So on the one of the third generation relatives had this gene mutation. So we got 2 probands, and so we then got the samples of the wife, husband, and the father-in-law just to establish the linkage and get going. Next slide. So this was the report of their third generation cousin, which just helped us. Yes, and then, we could get those in the pre-PGT workup. We could get some fully informative and semi-informative markers, and the lab could help us in establishing a pre-PGT pre-PGT workup for this patient. Next slide. And we did, we did the IVF on her, and I could just make 3 blastocysts for her. And I asked her if she would like to do an embryo pooling, but then she refused. She said, "Ma'am, if it is happening, it's happening. Otherwise, I don't want to do it again." And then, we were lucky enough to get 2, embryos, 2 normal embryos. But then husband again in the end refused for transfer. He said, what if I have a previous slide, please? What if I have the disease and then I don't want mere bachon ka kya hoga? This is what he was saying. And now recently I got to know the husband has developed this problem, LNMB1 gene. He is developing those autonomic symptoms, and he's just not willing he's not able to think about his wife, that if he dies, what will happen to the wife, and he's just not ready for this embryo transfer. So this is like quite a big, it's a very difficult situation. Next slide, please. So just a word on the post-PGT follow-up of pregnancy and invasive testing. As per ACOG March and October 2020, yes, although the misdiagnosis rate is less than 2%, it is very minimal, but still to date, the recommendation is that you have to confirm the PGTM with either a chorionic villus or an amniocentesis. So this has to be done. Although there are no reported cases of misdiagnosis as till now, HFEA does not report of any case, but yes, till date the recommendation is that invasive testing has to be done. Next slide, please. So just to conclude, yes, I want to say that PGTM is promising. It gives affected couples a chance to get rid of the genetic disease in the family. It does raise many ethical, moral issues. Each case is different and has to be handled as single on. The data today, there are very few centers who are exclusively doing. As we do more cases, as we move into this technology, yes, we'll be getting more and more experience and genetic diagnosis, yes, needs to be established in these cases. With a good IVF lab, day 5 biopsy, the misdiagnosis rate is quite minimal. And to date, prenatal invasive testing is recommended. So I thank you all for the patient hearing. Please pardon me, I'm a clinician. I try to, every day I'm learning genetics. So my geneticist, Dr. Sangeeta, she helps me a lot. When I'm privileged to build up a nice team here. She's there with us on board each time. For every small thing, we are pinging on her and, she's here to guide us. So this is how, I had gone to this Thermo Fisher lab, I think some 6-7 years back. And then they recommended, ma'am, you should buy this machine, NGS machine. And then I was like scratching my head. The only thing which I learned from their workshop was, yes, PGTM, it holds promise, but then it has to be combined. You cannot work without a good geneticist on board. And since then, I went to SGPGI Lucknow just to get into the world of genetics, get a glimpse of it. And then, was searching for a geneticist. Fortunately, we found one, and we have a good fetal medicine expert who is there with us on board. So we three worked together in Corson, and that is how we started the PGT program. Till date, the experience is not too much. So we have done some 10 odd cases, 10, 12 cases, and yes, learning day by day. So I think I would just request Dr. Sangeeta, our geneticist, is also here. If someone can unmute her and if she has something to add, I would appreciate that. Thank you very much. Finally, I could present. Yeah.
So thank you, Dr. Sheetal. It's been a wonderful presentation, and I'm in awe that the clinician speaks a real geneticist language. I'm sure Fiona is nodding her head. And I wish all the clinicians in this country would speak with this level of confidence.
Oh my God,
I'm so sorry. No, it's really essential because I see a lot of clinicians actually running away when we use the word alleles and mutations. They don't even want to listen to us. Ritu and I'm sure you'll explain.
On this platform, there are better people, better clinicians who can speak better than me. But then,
the whole idea that you're considering understanding genetics with it was such a heartfelt talk. I must really appreciate you for that, and it's a wonderful discussion. Dr. Sangeeta, if you want to.
It's a big confidence. Thank you, and please pardon me for all the wrong words which I would have used. I tried to comprehend, but then there's always a slip of tongue. You ask me anything about IVF, I would be in a better position to answer. I think Dr. Devika would agree to me. Anyways, thank you.
Dr. Sangeeta, I made you the co-host if you want to make some
comments. Good evening, everyone. I'm Dr. Sangeeta, and thank you, Dr. Sheetal, for giving so many good comments upon me. And your presentation was actually very good. Okay, so you are actually a geneticist now.
Anyways, so any comments from any questions we are open to, please. I think we should carry on with the meeting.
Because we are running short of time, I will just quickly run through a bunch of pointers which we have made from the previous meeting as well as some today's conditions. So who PGTM is for? I think I really love this statement. I think we can always consider as a part of our guideline. that PGTM is not for the couple. The PGTM is for the family. I think everybody agrees to it. That without the family, and absolutely. So if there is anybody else who really does not like the statement, please raise your concern now. But I think I'll be really wanting to make this as part of the guideline document, that when you talk of PGTM, it's a family which has to be involved. It cannot be just the couple. And we think, so unlike PGTA, which is so very linear and straightforward, PGT-SR becomes slightly complex, where you probably just need the couple and maybe, if possible, one of the affected embryos. But in PGTM, you need the whole family. Just one quick question. Anybody who may want to answer it? We are talking of PGTM as of currently only up to the Mendelian disorders. Are we ready to consider PGTM for hereditary cancers? Or we think it's too early for the country?
I think we should add on and also include for late onset diseases.
Late onset diseases as well. Okay, great. Thank you so much. When it comes to counseling, I think it becomes a very integral part. And Dr. Sheetal, one clear message that was coming from you was that PGTM counseling is not like the preconception counseling or prenatal counseling. It's completely a different ballgame. Do you think it's time in this country we should ask the Board of Genetic Counselors in the country to define modules for infertility counseling in general, infertility genetic counseling, and pre-implantation genetic counseling for PGTM?
Absolutely. I think this is very well said. It should be done. Yeah.
Okay, so I think this should come as a very clear recommendation from this committee as well, and we'll consider debating over this further. I will get in touch with the BGCI and we will try to do so. If any one of you who are a part of the BGCI listening to us or within this platform, and if you think we can take this up on a very serious basis, that can we develop counseling modules for genetics and infertility, because I completely agree that it's not counseling, preconception counseling or prenatal counseling. It's a really couple who is suffering from infertility and now also a secondary problem, and this would require a unique set of training. I think it's very clear from your presentation, and everybody would agree to it, that pre-workup is very, very essential, especially in the lab where you are doing the PGTM, which is very much unlike the PGT-SR, where you are okay using somebody else's report, but in PGTM it's no. 3-generation pedigree information available, that's ideal, and you would definitely want to consider that linkage analysis should be a part of the PGTM program, right? I don't think anybody would disagree on that. Choosing lab for PGTM, I think, Fiona, you'll consider it in your upcoming program or maybe in your next talk. I know we are running short of time. A minimum number of embryos, I think you said we need to pool. I don't think we can come to a consensus by just a linear discussion. Maybe we can have some sort of more brainstorming. And confirmation prenatal diagnosis is, you think, essential, or you think it should be recommended, or you think it can be just sufficient to follow?
It should be recommended. It should be recommended.
But we can leave it to the patient, because considering that they've conceived after infertility, they may not want to touch their babies at some point. So recommended, but not mandatory. Should that be okay, considering that the misdiagnosis rates are very low? The final question, I did see at some point you did mention that you can combine PGTM and PGTA. Is it practical for the clinics and for the laboratories who are offering it? Because now anyway, we are dealing with fewer embryos. Now we're wanting to make it more fewer by combining PGTA. Should we say it is mandatory or it is optional?
It is optional. That is very, very clear that it is optional, but it's open to discussion. I mean, you know, I'm very scared. You know,
I think Dr. Ritu had mentioned something in terms of the fact that there should be a different set of indications for combining PGTM and PGT.
For autosomal dominant conditions where the embryos are less available for testing, I did a recent case on spinocerebellar ataxia. It is an autosomal dominant condition. That particular patient had only 6 embryos. And out of 6, only 1 PGTM was negative, I mean normal, and PGTs all were normals. So that depends. If you have less number of embryos, if you have only 1 available normal embryo, I wouldn't test for PGT. I would just transfer if it's PGTM normal. Depends on indications.
I also think the patient is a critical part of this part of the discussion, because they did all this expensive procedure for PGTM just to avoid termination. And they should not have to, terminate fetus for trisomy that could be detected with the sample that we already have. So, we should give the option to the patient as well while making.
So we leave the option, we leave it optional, but I think maybe we can, as a guideline, we can say that if it is indicated, do consider it seriously. But if not, in a standard and non-indicated case, maybe if the couple is already fertile and just coming for a PGT, maybe we may not consider it. And counseling again becomes a very integral part of this business.
Correct.
I think with that, we have come to the end of these discussions. I'll leave it now, open the platform to Fiona, who will quickly run us through what are the requirements that one should look for while considering offering PGT in their clinical practice. From the laboratory perspective, we will have a quick run through. And I must remind everyone that at some point as IFS-SIG, we will run a specialized webinar or possibly a physical meeting where we will brainstorm again that what are the minimal essential requirements for a laboratory when they start offering PGT programs. Over to you, Fiona.
Thank you. So I would like to discuss now how to choose the right lab for PGT. But before I get into it, I would like to give some disclaimer. This discussion is completely academic. I do work for a genetic service provider, and my discussions have no preference to our company or any other company for that matter. Okay, so while making a choice for a genetics company, of course, you have a wide range of genetic service providers now, especially in India. It's the next genetic hub of the world. And the first and foremost thing we need to know while choosing the genetics lab is the technical expertise, because without this, it is completely handicapped. So have a look at the qualification of the personnel involved in the genetic testing. How is their support system? What is the qualification of their geneticist? What is the qualifications of their genetic counselor? And as Dr. Deepak rightly mentioned in the previous discussion, find out if the genetic counselor has experience in counseling IVF patients and reproductive genetics, particularly in the fertility segment, because most genetic counselors are experienced in the prenatal division or the cancer division, and they do not really understand the mindset or the limitations of IVF. And that's something very important when you're choosing a genetic partner. Since most of the IVF labs do not have their in-house genetic counselors, they are dependent upon genetic service providers to provide their genetic counselors. And that's why it is extremely important to know the experience of the genetic counselor who will be handling the cases for you. Next comes the verification and validation of the genetics lab. Usually, when a genetics lab starts their validation, it primarily starts with PGT-A, and this can happen at multiple levels. And the first validation happens when the baseline is set, when we run genotypes for at least 50, that is the SRA recommendation, 50 euploid males, 50 euploid female karyotypes, which are then followed by DNA concentration experiments to titrate the mosaicism dosage, and then validation of the resolution limit of the test. So standard PGT service providers will provide you a resolution of 10 MB for PGT-A, and it changes for PGT-SR and of course for PGT-M. And then comes the reporting structure. Ask for a sample report, go through it, see what is, they need to declare what are their reporting guidelines, what level of mosaicism are they going to report, how are they going to report this, and what are the guidelines they are following. Are they following just SRA? Are they including ASRM or any other guidelines that they would like to include? And the most important is the regulatory submission. So regulatory compliances and the certifications of the genetic companies also important. So on here, I would like to stress about one thing. We have a genetics lab of our own, and we do still get so many requests from other genetic laboratories saying that they will send the samples to us and they're going to report through us. And that is something that most genetic companies who are the standard 5 companies of the country refuse to do, mainly because of the quality control assurance and also data sharing, because this involves gender determination as well. And most of the softwares are masked, but data sharing for gender related information is banned. So therefore, you need to know that your PGT laboratory is performing PGT in-house. Ask for a lab visit, go have a look, and then you would know for sure that they have the instrumentation, they have the equipment, and they will have their own data, how they're going about with this. I was stuck. Share it again. Okay. So how to judge the quality of the PGT lab? The quality assurance is mainly determined on multiple parameters. First thing is the equipment, and this ranges from not just an NGS machine. There is so many things that come before NGS, after NGS. So well-equipped genetics lab will be able to give you comprehensive coverage for the tests that require to support PGT. It is not possible to do PGT in isolation. That's not how you establish expertise. How was the test validated? You can talk to them, you can go through HLA guidelines, and then you can have a clear idea on how the test was validated and how is the performance of the test in the laboratory. Are they able to explain the limitations of the test? So if a lab is over exaggerating their PGTs or coming and telling you this shows 100% pregnancy, you already have a red flag to know, because we know for a fact that PGT is not going to improve your pregnancy rate. It's not getting you pregnancy in the very next cycle, because this is a multifactorial event. What about the internal quality control measures? So the labs usually, we perform frequent internal quality control checks. We look at the protocol that is followed, the SOPs that are made, and also every quarterly assessment of the data that we generate and what is the percentage of, say, whole genome amplification success rates, or how is the mosaicism level. All these are titrated from time to time. Find out if the lab is part of any external quality assurance program. So you have UK-based GenIQuas programs, which will send us WGA samples of known genotype, and then we are supposed to report it to them, and they will evaluate how it goes. Find out if the team is skilled to carry out the tests, and what are the specimens that they have used. For example, our laboratory used amniotic fluid samples, POC samples, for which we knew there were deletions found, and then we revalidated our resolution limits based on that. And how is the test reports reported? How are they filed? Or are they submitting all this information back to PCPNDT? Because every PGT test that we do needs to be reported to them. When it comes to accreditations, ISO is the main accreditation required. So usually the minimum requirement is ISO 9001, and the scope specifically asks for ISO 15189. So this is mainly for laboratory compliances. And this is also provided by our NABL in India, and which validates and accredits labs based on the same ISO guidelines. And it is important to know that in their scope of services, molecular testing should be included. You can also you need to ask for the PCPNDT certificate of the laboratory. Make sure the name of the laboratory is right. That way you know for sure that this is a lab which is licensed under the government and not using a third-party genetics lab to give you results. There is a Form B for every genetics lab, and they need to have the approval for genetic laboratory for chromosomal studies, biochemical studies, and molecular studies. Only then are we allowed to test embryos for PGT. This is the GenIQuas quality control assurance programs that I talked to you about. They have a two-step performance criteria evaluation. They will evaluate if the report is correct, and they will also evaluate your reporting structure in line with HRA guidelines. So they will give the lab the feedback to improve their reporting structure, to include all the information, and then they give you a score to approve it. So validation is a critical point for ART centers as well as PGT centers. So there are two parts of it: the validation of the lab and the validation of the genetics lab. So when it comes to an IVF center moving into a PGT center, lab validation comes first, but some companies will accept lab validation done by other companies as well. That is completely okay, because this is a process related information. And in India, we do not have the same lab structures as that of Europe or US for that matter. So there aren't significant changes that are happening in your IVF laboratory based on PGT alone, unless you are changing the structure. So what is most important is the embryologist validation. An embryologist who is not validated for biopsy, who has not completed about 100 embryos biopsies. That was the consensus of this team. We do not want these embryologists to be biopsying our embryos. It is a big risk to be taken. And usually biopsy of day 5 embryos is what we prefer. At least 6 to 10 embryos need to be used for the validation run. That means the samples that go to the genetics lab, not the practice set. It's important to assess embryonic survival post-biopsy while practicing biopsies, while validating the lab. It is also important to assess freeze-thaw survival, and then the WGA success rate, which should be at least above 95%, and to make sure that a negative control has been sent. This gives us an idea of the work environment in the IVF lab. So this is if you're starting the PGT in your IVF lab. What if you are already a PGT center, IVF center offering PGT, and you're switching service providers? So you might be familiar with the protocol of your existing service provider, which might be slightly different from others. So it is always advisable to ask a new genetics company to give you a dry run. This way you will get an idea what are the changes that are implementing, what is the protocol, so that nobody is stuck in a last moment pressure. So this is something that most companies Europe also practice, that if your lab is already validated, they will do a dry run, which is kind of a mock validation for the IVF lab center as well. So there are coming to the instruments that are used for PGT. So we have next generation sequencers from many different companies and many different versions of these machines. And the most common are, of course, Thermo Fisher's ion Rebiopsied model, and Illumina, of course, has many different models of their NGS machines. And what I would like to see is, from all the data that we have evaluated, both equipments perform identically when it comes to molecular karyotyping, which we do for the PGTs. So the performance of these equipments are, of course, different when the application is different. But for this particular application, for a CNV testing, they perform identically. The manufacturer gives a resolution of 10 MB, which we can easily do. And of course, you can actually develop the assays. The number of embryos we test increases, our data points increase, the baseline testing and setting gets better. We can, as Dr. Ritu also mentioned, you can go down to even 2 MB with this resolution. So both can detect mosaicism also at the same level. There's a minimum of 20% detection limit of mosaicism. Anything below that is euploid. Anything above 80% is aneuploid. This is old consensus. So now there's a new consensus coming into place that any embryo below 50% mosaicism should be reported as euploid. And this is something this SIG will also work on to develop consensus how we are going to have genetic report, PGT reports in this country being made. Aside from PGTA, what else should we consider between the two companies? The Rebiopsied model, what we commonly use, is way more user-friendly. It allows us to batch more samples. You can automate it. The time taken to run the test is lesser. So it is a little more efficient when it comes to a labor elaborative workspace compared to the Illumina protocols. But nonetheless, both can be done for this particular application. So it doesn't really matter. The critical part when you evaluate a genetic company is the first and foremost the response of its scientific team. The marketing team will come and tell you many stories, but when you talk to the scientific team, you get some level of clarity how they're working. So is the lab able to troubleshoot your problems? How are they managing WGA failures? Are they able to explain it to you? Are they able to explain this to your patients as well? And usually WGA success rate is preferably above 95% for all standard genetic laboratories. And you have to have a very clear idea what is going to be their reporting policy, what is going to be their billing policy. What questions not to ask? This is something I get very frequently. What is the pregnancy rate of your laboratory? It is literally impossible to evaluate a genetic laboratory based on pregnancy rates. Pregnancy, first of all, is a physiological event, and there are so many factors involved in it, and a euploid embryo is only one of them. And also, genetic laboratories work with different IVF centers, and it is very difficult to ascertain the pregnancy rate, though this data helps us develop artificial intelligence networks above the baseline assessment of what is already provided by our service providers. So we develop our own assessment modalities as we gain more sample volume. So while choosing new diagnostic tests, I think it is very important to choose wisely. We tend to lean towards new technology. It's a very good thing. We should be flexible and accepting to new technologies, and we should be able to evaluate scientific information critically rather than what we want to believe, because many minute things get lost in communication when a certain laboratory is marketing one particular thing. So the scientific side of it should be considered very clearly before offering new technologies to patients, and patients should be counseled clearly. So now the biggest challenge we face is patients read everything on Google, come and say, I want this. So it is important. This is what we usually address to our patients. It is important that you acknowledge the clinical expertise of your physicians and clinicians who will be able to make the best decision for you. Second thing that the next thing you need to evaluate is the transport system. So is the laboratory well aware of the transport system? What do they do if the sample is not delivered? How do they track the sample? Do they have a proper agreement with transport companies? And how is this going to affect the efficacy of PCR amplification? So what are your agreed upon turnaround times with different companies, and how you are able to ship these things? So ideally, there are two main transport modalities for embryo biopsies. Either we do a cool pack shipment, which handles this at about -20, or you do a dry ice shipment, which handles it at about -80. The advantage of dry ice shipment being it can keep your sample steady at least until 72 hours. And anywhere in this country, you can reach those samples. You can top up dry ice and get it safely into into the genetics lab wherever it is placed here. And one of the most important things you need to acknowledge is review your contracts. Make sure that you have a proper agreement between your center and the genetic testing laboratory, because this safeguards you legally in so many different ways, and it also details your terms and conditions of agreement. And this is something I too face a challenge with. Not everybody is ready to sign an agreement with a particular genetics company, but it is what legally safeguards us, and that is something that we should be opting for. And you can always have an agreement with more than one company, but whatever agreement you have with a particular company should be done in written documentation. So what I would like to say is make informed decisions, review the credentials, see the support system, because that matters the most. See if they can follow up with your support. How clear are the companies? How are their validation protocols? And ask the right questions. So I would like to conclude that expertise, the consulting, the support system, the knowledge, and communication is one of the key factors that determines the right PGT laboratory for you. Thank you.
Thank you, Fiona. That was a wonderful and a very crisp talk. And several take-home messages which you have really nicely put up, and I would request you to take a primary lead and prepare a nice document which can be circulated across the country and used by the clinics, because we must also understand that webinars like these also have limitation for the numbers of people who have attended, and it's a lot of big group discussion. So I think it's very wonderful. I really liked your point that we should not permit any sort of third-party testing especially for PGT. Obviously, we don't do that for PGT prenatal, but also for PGT, and that has to be taken care by the clinicians. Quick questions to you both, you and Ritu. But before that question, I think there is one question on the YouTube link, which is asking, and I think is a very pertinent question to answer, that when there is a couple without RPL or any previous history and still has a heterochromatic or those standard variants which we see in the karyotype, do you still consider them as patients for SR, or do you think we should wait for them to fail cycles and then go ahead?
I think if they had repeated miscarriages and they are seeking an IVF treatment for that, I would ask them to opt for PGT-A or SR. But then if they are first timers and just trying for pregnancy, came for an opinion, I wouldn't push them for PGT.
Okay, so it is only when there is a double indication.
Yes. In an absence of infertility and absence of any pregnancy loss, the first time, no, we can just take a chance, because you have plenty of couples with these polymorphic segments that do conceive naturally, that they never know about this. So not in the first cycle.
Great. Thank you. I think that was a wonderful pointer, because otherwise the take-home message wasn't too clear that whether we can start offering it for all. No, it's not for all. That if there is a variant associated with a bad history, then we may consider it. Great. But just two quick questions for both of you, because we are really running short of time. We are 45 minutes late already from our scheduled time. But do you provide, so both of the labs, that is for at least the two lab people are here, that do you provide trained embryologists to the clinics who would wish to do a PGT-A? So do these companies consider having a pool of embryologists who would go and do a biopsy and get the samples, or you think you always want your IVF labs to have pre-trained embryologists? Fiona.
We do have associated embryologists who can do this and help out first-time IVF laboratories. Even if the embryologist is newly validated, they do sometimes prefer someone else from outside, an expert, to come so that they fill in all the gaps in their training. But in the long run, it's always preferable for your in-house embryologist to be performing the biopsy, because this is their lab they are manipulated, they are embryos, they're going to thaw them. So it's better if it is one person handling the entire process.
No, so the question was slightly in a different way, that do you think that is a part of the guideline document? Should it be that the labs who are offering PGT services should have a panel of embryologists ready in case needed? Or you think no?
Yes, they should have panel of embryologists ready in case one is not available, because all the panel of embryologists should get validated by the geneticist, especially in the PGT, the cells, how many cells have been taken, whether all the cells have shown amplification. All the embryologists needs to get pre-validated.
Yeah, so I think that was a part
Absolutely.
of our document, but I think this also becomes not just a part for the IVF labs, but also part for the companies who are offering these services, that they should perhaps. And the same question applies for counselors, that number one, do you provide, as companies, do you provide training to counselors to deal with the infertility segment of counseling, genetic counseling, or you think that, I mean, how do you go ahead doing it?
I have a panel of 6 counselors which are specifically trained for fertility genetics, who mainly deal with counseling for RPL, RIF. And these counselors, when they came to us, did not know so much about embryology and IVF, but we did put in a significant effort. We had 6 months of shadowing to make sure that they know exactly how to handle IVF patients. And I think most genetic counselors will agree with me, handling IVF patients is completely different from handling any other specialty. They should be trained specifically for this.
Ritu, any opinion from you?
Yeah, I think counselors can be trained, and wherever there is a genetic counselors are always available even on phone. So I think we should have a registered counselor, genetic counselors available for our country, and whichever state is preferring, they can be contacted.
Okay, great. So I think as companies who are providing services, should one have a panel of embryologists as a part of their team and a panel of pre-trained genetic counselors, so that the services can be optimized for the country.
Deepak, I would like to suggest how Western countries, especially the USA, has a database for genetic counselors available. We Indians should also have a database of genetic counselors, so whomever they want to refer, especially who is trained in cancer, might not be able to answer reproductive side.
Now, Ritu, we must remind ourselves that, we must remind ourselves that in this country we have probably only 300 to 500 trained counselors, which are, I mean, almost 70% of them are, for cancer counseling and perhaps for prenatal. We have a very small pool. So, there is definitely a need for more counselors. I agree with that. But, at the same time, we need to optimize our counselor usage, because IVF segment cannot gobble up all the counselors, because other segment also need it. Dr. Sheetal, you wanted to make a point.
No, it's just that we had a very bad experience. I mean, sort of, she was an absolutely new counselor, and we called her initially, and then, for 2 or 3 patients, but then she couldn't, ultimately we realized that, it is not serving our purpose. So I think if we have a board of trained genetic counselors, it was very, in the beginning, I'm talking about 6-7 years back. And then if you have, we know that, okay, these are the genetic counselors who are there on board, and, maybe those who do not have an access to a geneticist, I mean, that will be a very big help.
Great. So there is a board of genetic counseling, or there's a board of genetic counselors of India, BGCI, who trains and certifies counselors, but I'm not sure whether infertility counseling is a part of their training. Fiona, any points?
Yes, BGCI certifies counselors based on general genetic risk assessment. I think we can talk to Dr. Ani Hassan and talk to her.
Yes.
On their website, if you go to BGCI website, you will find a list of counselors who are board certified with BGCI. And we can ask Dr. Ani Hassan to include their specialties into this website, so that everybody can reach out to them and know who are they and what they specialize in.
Sure, I think the next webinar with IFS-SIG applied genetics should be with BGCI,
yes,
so that we can bring out this
definitely. I think I'll make that note.
Yes, yes.
Yeah.
So as of now, through our SIG applied genetics, we did try to see that if we can have a list of counselors which we can circulate, but I think we were not very successful, because not all counselors are very free and open to come up and talk about, because they're already too occupied with their practices. So we need to come up with a more practical solution, maybe a short-term solution and then a long-term vision. So I think that should be one of the responsibilities of our group. I think with this, we come to the end of the meeting. I'll leave I'll request Sayali to make a few pointers and what final comments, and then we'll sign off from here. And anybody wants to make any other comments, more than welcome.
All right. So thank you, Dr. Deepak. So I'll just basically be talking about a few pointers that we made during the conversations, during the presentations, and then according to the YouTube questions and the Q&A questions that we got. So one of the things that we have added to look at is what are the indications for PGTA is time to pregnancy reduction and indication. So we have added this question in the survey immediately so that we get a perspective. We have also made a note that the different technologies utilized for non-invasive especially can have different outcomes. So we will be taking this in our NI-PGT part of the webinars that we will organize. We also have made a note that we need a separate focus group discussion for prioritizing of mosaic embryos, and we need to make a list of the stakeholders that are involved in this decision making, especially the geneticists attached to the genetic labs and the clinicians. Also, we have made a note of the heterochromatin variants that have a role in RPL and RIF, and I think we should be making a different list of these that are involved, and we need the data and the input of the genetic labs that have been working with these patients so that we can list it out for the Indian population. The other points that we have noted is a separate list of indications for PGT and PGTM combined if required. And that we need to add in the guideline document that PGTM specifically is not just for the couple, it's for the family, because there is a complete involvement of the family and information required from that side. And the next webinar, we want to do it with the Board of Genetic Counseling. We will work towards that and try to it's up to Dr. Deepak, I think, mostly to make that connection and see whether we can get some of the changes done for the Indian counterparts. Other than that, we also have questions on the embryology KPIs required for biopsy. We haven't covered that much particularly in this webinar because we covered it quite in detail in Fertivision, and we have put those questions on the survey. That what are the KPIs that are required for the whole biopsy procedure for the genetic laboratories in the embryology laboratory and beyond, for the pregnancy rates, etc. And whether what kind of hereditary disorders should be added for PGTM as indications, and for which PGTM can be added. So these are the points, extra points that we have made from this webinar, and that we'll be working towards.
Can I just add, I think we need to have some kind of a grading for mosaic, how are we going to deal with mosaic embryos?
Yes, ma'am. So basically, that's what I've written. We will need a separate focus group discussion of stakeholders for prioritizing mosaic embryos. So we need your help because you are prioritizing mosaic embryos with a lot of specifications for the Indian population. And we need to speak with you and a couple of others to look at how to do that for the Indian population. But because we have these guidelines from PGDIS, but are they really applicable for us is something that we'll have to create an entire different focus group for. That's satisfactory for the next steps?
Yeah.
Okay.
I think with this, we come to the end of this wonderful webinar. I thank everyone on the behalf of ICMR-NIRRCH and as a convener of SIG Applied Genetics to be here. I see that when during almost throughout the entire meeting, we had about 40 to 45 participants on this platform and almost the same numbers on YouTube constantly viewing us. And even at the end of the fact day where we are nearly 1 hour late, I see so many participants still being there. So that shows excitement and the need felt by the people for such a kind of meeting. I thank each one of you for sparing out the time and giving your presentations, discussing all the very important aspects of this thing. And I think we should make our own guidelines so that will be better for our clinicians, our labs, and our patients finally. Thank you so much. Signing off from here. See you everyone soon, and we'll have more such meetings. Thank you so much.
Yeah, thank you so much.
Thank you so much. Thank you for your time.
It's great working with you. Thank you so much. Thank you.
Thank you. I think it's been a great session. Very well.
You.
Thank you.
Request to everyone
Thank
to
you,
take
ma'am.
up the survey so that we can have
Please, the survey has been populated. Sorry, I took over. The survey has been populated on the YouTube link as well as in the Q&A. I will also be putting a Facebook post, a LinkedIn post, an Instagram post, and also, Dr. Deepak will be doing the same to make sure that most people are referring to it and filling the survey. We know the survey is a bit long. Please take out 10 minutes of your time. If you have any questions, you can put a message to us. I have a group of interns that are working on this, helping people fill it out. So we'll be happy to help you. Thank you.
Thank you so much. Bye. Good night. Have a nice weekend.
Thank you. Good night, everyone.
Good night, everyone.
Have a great night. Bye. Bye.